Mm. All right, let's begin then. Today we'll continue the neurology and hello, voice clear? No double voice. Everyone just give me a thumbs up if voice is clear. All right, let's begin. So today we'll be starting with the second part of neurology from the movement disorders. So we'll be covering ear, eye, and even pharmacology. Ear, there is nothing much to do in ear. Just one disease you have to remember. Rest ear you can avoid. Ophthalmology we have to do so many things, and pharma will be doing this. Okay, so let's just begin. Okay, so let's do this. So this, and on this page, they have given different types of movement disorders. Now, see, you have to be familiar with all these terms. Okay, you have to be familiar with all these terms because in the question they won't explain you what type of movement is going on. Like they will explain you if they want to, or else they can directly give you these words. Okay, so if you are thorough with these words and if you know what is the meaning of these words, you will be good to go for the diagnosis making. Okay, so let's just see the first one, that is akathisia, restlessness and intense urge to move. Okay, can be seen with neuroleptic malignant or as an adverse effect of Parkinson treatment. This akathisia is also seen in when we say take the antipsychotic drug. Okay, so it is also seen there. So these are few points that you need to keep in mind. All right. So coming to axial axis flapping tumor, it is seen in hyperammonemia. Flapping motion, hyperammonemia. Okay, whenever you hear the term axial axis or flapping motion, the hands are moving in the flapping motion or the flapping tremor. Always think about hyperammonemia, and as a result of hyperammonemia, there can be encephalopathy and everything like that. Okay, so these are one word that I am telling you on the basis of which you can identify the movement. Okay, all right. Coming to atetosis, slow snake-like writing movement, especially seen in the fingers. Okay, it will be like this. In the fingers only it will be seen. Okay, and they will clearly mention you if slow movement is seen in the fingers, then only you will think about atetosis, or else you won't think. Okay, so read the question, they will mention you specifically what they want to ask. Okay, coming, and the location is basal ganglia, Huntington disease it is seen. Chorea, sudden jerky purposeless movement, again basal ganglia, and chorea dancing, Huntington disease. Okay, coming to dystonia sustained involuntary muscle contraction. So here also you can see it with antipsychotic. Okay, antipsychotic. उसमें we have seen acute dystonia, akathisia, tardive dyskinesia. So all these movement disorders are seen with the uh, antipsychotic as a side effect. Okay, so these are all the part of an extra pyramidal system that we see. Okay, so what are the special things that you need to remember here is writer's cramp, blepharospasm, and torticollis. Let me tell you the meaning. Blepharospasm means eye twitching, and in torticollis it means twisting of head at one side. Okay, So torticollis means twisting of head at one side. Twisting of head at one side. Okay, so it will be like this. Torticollis is mostly, they ask in a pediatric subject like a baby is born with a torticollis neck. And in U World also they have asked this one question regarding torticollis. Okay, if you remember very well and good, or else it's okay if you don't because that's a part of pediatrics. And only one question has been asked in U World. I don't know for what reason. Okay, so these are the meaning that I have told you, and why the twisting is occurring because of neck muscle contraction. Okay, so you can write this down. And what else is there? Yeah, that's it. Yeah, sometimes in Korea and dystonia, as I told you, antipsychotic. But in the exam, you might not remember the class. So the most common drug that you need to remember here is haloperidol. Okay, haloperidol is the first generation antipsychotic, as we have already discussed. In both of this, okay, haloperidol. Now coming to the next part, that is the essential tremor. High frequency tremor with sustained postures, worsen with movement of an inches. Okay, not needed. Often familial. Patients often self-medicate with alcohol, and this line is very important because in the question they will give you patient like he was having tremors in the hand, and when he took alcohol, the tremors went away. Okay, this line will be present in the question. Okay, in UWorld also I think one or two questions in NBME, so many questions are there regarding essential tremor. So this becomes very high yield, and this line is very important to help you with the diagnosis. Okay, and the treatment is non-selective beta blockers. Okay, treatment you can do it. Coming to intention tremor, slow zigzag motion when pointing or extending towards a target. Okay, this is what a intention tremor is. That is because of dysfunction in cerebellum. Yesterday we saw, okay, nose to finger test. So nose to finger test won't be straight, it will be like a zigzag. Okay, so cerebellum ka dysfunction. Coming to resting tremor, uncontrolled movement of distal appendages limited by intentional movement. Okay, seen in subtension diagram. Occurs at rest, field rolling tremor of Parkinson disease. Okay, now see Parkinson's में जो tremor आएगा ना, the patient will be sitting at the rest. Okay, whereas when you see about the essential or intention tremor, you see the patient is trying to do something and then the tremor is arising. Okay, so may mark these differences. Parkinson may it will be occurring at rest. Tremors will be occurring at rest, but in various other symptoms of syndrome, it can occur with a movement or with the intention of starting a movement or anything, something like that. Okay, so resting tremor. Heavy embellishment. Sudden wild flailing of one side of the body. Okay. Wild flailing of one side of the body means one side of the body will be dropping down. Okay. जैसे कि बेल्स पाल्सी में एक साइड का फेस ड्रूप हो जाता है, वन साइड ऑफ द फेस ड्रूप डाउन, similarly the one side of the body will be drooping down or it will be jerking. Okay, something will be happening but only on the one side, and that is what known as hemibellishment. Okay, so contralateral subthalamic nucleus, this is very important. Subthalamic nucleus, contralateral subthalamic nucleus. Many questions have been seen in NBME. Okay, so this is important. All right, myoclonus, sudden, brief, uncontrolled muscle contraction, jerks, hiccups, common in all those. So this is myoclonus is a type of we see in the seizure disorders. Okay, myoclonic seizures. And coming to restless leg syndrome, uncomfortable sensations in the legs causing irresistible urge to move them, relieved by movement, worse at rest and night time. Okay, associated with iron deficiency, treatment dopamine agonist. Now see, restless leg syndrome also occur at rest. Parkinson also has to occur at rest. But once you start moving, the restless leg syndrome will be lighten up, but Parkinson's won't lighten up. Okay, there is a difference between Parkinson and restless leg syndrome. And see, all these terms that we are seeing, atetosis, chorea, ataraxia, akathisia, dystonia, all these they will be using in the question. So you should be familiar with the terms, and based on this, you should be knowing what is the question asking you about. Is it particularly asking you about tremor? Is it particularly asking you about some collective disease? Okay, so everything you need to be aware about. Okay, so this page is very important. So do this properly. And yeah, along with this movement name, remember which location is responsible for causing this trauma. All right. Moving ahead, neurodegenerative disorders, very high yield part of pathology. Okay. So let's just see first one. That is the Parkinson's disease. ओके, तो पार्किंसन डिजीज में देख लेते हैं क्या क्या याद रखना है. बेसिकली इन जनरल लैंग्वेज एवरीवन न्यूज व्हाट इज द पार्किंसन डिजीज. इट्स अ ट्रेमर अकरिंग एट रेस्ट. At rest is very important. Okay, let's just see what they have told. Tremor, pill rolling tremor at rest, rigidity, akinesia, postural instability, shuffling gait, small handwriting, everything. So out of this, I think 2 or 3 symptoms will be given to you in the question. Okay, so here the see symptoms are easy to pick out. Symptoms are easy to pick out. Mark my words. Now the question they will be asking you is about what will decrease over here. So dopamine will decrease as we saw in the basal ganglia part, substantia nigra. Okay, so if it is a Parkinson, the substantia nigra comes into play over here. Okay, and where is substantia nigra located? It is located in the basal ganglia. So if the question says that the Parkinson is a disease caused by the defect in the basal ganglia, you don't have to confuse. You can choose basal ganglia. Another thing, yesterday I showed you one image. The substantia nigra and the entire basal ganglia is located in the midbrain part. Okay, so instead of substantia nigra, instead of basal ganglia, they might say midbrain. So you should not be confused that midbrain भी हो सकता है answer. Okay, so there are many possibilities of answering Parkinson disease ka location. Don't get confused. Okay, let's move ahead. Lewy bodies. I'll rub this and write it. Midbrain. Okay, now this Lewy bodies is important, composed of alpha-synuclein intracellular eosinophilic inclusion. This line is very important because sometimes if you are not able to make out what is the diagnosis, Lewy bodies will be given. Now again, Lewy bodies is also present over here. Lewy body dementia. Okay, so let's just see what is the difference over here, but let's just first complete Parkinson. अगर Lewy body आता है एग्जाम में, you will be having two possibilities, either Parkinson or Lewy body dementia. Okay, most commonly they will be asking about Parkinson only, but in UL Lewy body dementia has also been asked, so we'll discuss that also. Okay, so देखते हैं dementia is late finding MTP, a contaminant in illegal drug, is metabolized to MPP plus, which is toxic to substantia nigra. So this is one, but I have never seen anyone asking this. Never seen anyone asking. But you know why it is important? Because again, in the UL, in one of the questions, in one of the options, MTP was given. Okay, MTP was given as one of the options, and it was related to some movement disorders only. So you should be knowing this line. Okay. So let me just see what other things you need to remember in Parkinson's. Nothing else. Okay, nothing else you need to remember. All these 3-4 points are important. Symptoms are easy to pick out. Tremor hoga at rest. Then dopamine will decrease. Where is this lesion occurring? Substantia nigra. What are the possible answers? Midbrain and basal ganglia. Okay, MPTP is a contaminant found in drugs. Okay, so ये आपके सारे हो गए important. And one like most definitive feature is alpha synuclein. What is alpha synuclein? It is a eosinophilic pigmentation or inclusion. Intracellular eosinophilic inclusion. Okay, so this is all you need to remember for the Parkinson. Now we'll come to the next page and let's see the Lewy body dementia. What is given over here? See, in Lewy body dementia, they will give visual hallucination, but in Parkinson, they won't give visual hallucination. Okay, hallucinations होना जरूरी है for Lewy body dementia. Okay, and that's it. ये they can give you the symptoms similar to Parkinson. Parkinson's के similar symptoms होगा, but one thing you need to pick out, dementia hallucinations होंगे. Okay, so you can say Parkinson's plus hallucinations. Your answer will be Lewy body dementia, and here also you will be saying Lewy body. Okay, then what are Lewy bodies? These are what Lewy bodies is. So ठीक से देख लेना, Lewy bodies ऐसे दिखते हैं, and in the exam they might give you directly the image, and you need to figure out what is they are talking about. Okay, so I hope the Lewy body dementia and Parkinson disease का difference आपको पता चल गया. Moving ahead, we have Huntington disease. Now see, 99% of the cases, if they want to ask you about Huntington disease, now it will be between 20 to 50 years of age. Okay, if they want to ask you, 99% I have seen 20 to 50 years of age, and it is also given over here. Yeah, symptoms manifest between age 20 to 50. Okay, 51, 52 भी extend कर सकता है, but most commonly they ask about 20 to 50. All right. So let's just see. Autosomal dominant is important. Trinucleotide repeat is important. Okay, Huntington gene is important. So CAG is important. Huntington gene is important. Chromosome 4 is important. And see, all this we discussed earlier. Chorea, atetosis, there will be aggression, depression, dementia, sometimes initially mistaken for substance abuse. So, how typically the case will be of Huntington? Okay, the patient will be aggressive, plus depressed, plus dementia. At the same time, along with this, there might be some movement disorders also. Okay, so see, in the exam, you won't be asked to diagnose only on the basis of symptoms. Okay, they will say either they will give trinucleotide repeat expansion or they will say it is a hereditary disease. Now, hereditary disease को कैसे पूछते हैं? They will say कि this similar condition was seen in his father. Okay, ऐसे पूछते, they won't say that it is hereditary or it is seen in the family generation. ऐसे नहीं, they will say the same condition was seen in his father. Okay, because it's autosomal dominant and it has to be present in the first generation, second generation, third generation. I'm third generation if it is a patient, then second generation में भी होना जरूरी है, second से first में भी होना जरूरी है because it is autosomal dominant. Okay, so it has to be present in every generation. Okay, so these are the important points regarding the presentation of the case. Now let's see what are the biochemical presentation and anatomical presentation. There will be atrophy of caudate and putamen. Okay, atrophy of caudate and putamen is important. Atrophy of caudate and putamen. Increase in dopamine, decrease in GABA, decrease in acetylcholinesterase. Okay. Neuronal death via NMDAR binding and glutamate excitotoxicity. All these lines are very important. And I will just ask you one normal basic general question. If they have given glutamate excitotoxicity, which ion will be associated with this? Can anyone tell me? Glutamate excitotoxicity है तो इसके साथ कौन सा आयन रिस्पॉन्सिबल होगा? Come on, I want the answer. ग्लूटामेट एक्साइटोटॉक्सिसिटी के साथ कौन सा आयन रिस्पॉन्सिबल है? This is the asked question. You should be knowing it. I got this in the exam also. No one? Okay, so answer is calcium. ये लिख के रखो. Wherever you hear the word glutamate excitotoxicity, if they are asking about any channel disorder or ion channel disorders, think about calcium. Calcium का ही पूछेंगे और कुछ नहीं पूछेंगे. Okay, so glutamate excitotoxicity is always associated with calcium. All right, so let's just take a quick review about the Huntington disease. Huntington disease सबसे पहले तो 20 से 50 years, this 99% cases they will follow this. It is autosomal dominant, trinucleotide repeat expansion, aggression, dementia, depression plus movement disorders, and then atrophy of caudate and putamen. Now see, if it is Huntington, na, they will give you the MRI also, they will give you the gross specimen also. You have to identify where the problem is. Okay, so yesterday I showed you कि caudate और उसका ध्यान रख लेना किधर क्या होता है. So based on that, they can ask about Huntington also. Okay, so atrophy of caudate and putamen, increase in dopamine, decrease in GABA, decrease in acetylcholinesterase, then glutamate excitotoxicity death होगी. Which ion is responsible with glutamate excitotoxicity is calcium. Okay, and what other thing is, yeah, as we saw in the biochemistry कि trinucleotide repeat expansion का genetic term कौन सा है? Anticipation. Okay, so this is all you need to remember for the Huntington disease. Coming to the most commonly asked dementia, that is Alzheimer's disease. Look at the location, guys. Look at the location. This is all given in the latest edition. This wasn't given in the old editions. And why they have given? Because questions are being asked. Okay, so location सबके देखते रहना. And now let's see what is important in the Alzheimer's disease. Most common cause of dementia in older adults. Advanced age is the strongest risk factor. Down syndrome is another important risk factor. And this APP is located on chromosome 21. Decrease in acetylcholinesterase associated with following altered protein. Okay. Now what happened is ApoE2, ApoE4 you need to remember. APP, presenilin presenilin 2 you have to remember. And now see, ApoE2 is protective, ApoE4 is for Alzheimer's disease. Okay, this is how you will be remembering. ApoE2 क्या होता है? Decreases the risk of sporadic form, whereas E4 increases the risk of sporadic form. So there is disturbance between the E2 and E4. E2 से Alzheimer's कम होगा, E4 से Alzheimer's increase होगा. Okay, so this is the presentation that you need to remember. Most common cause of dementia, Down syndrome is the secondly most commonly asked question. Third, APP gene, chromosome number 12, 21, sorry, and associated with ApoE2 or ApoE4. ApoE2 decreases, ApoE4 increases. Okay, along with this some other genes are presenilin 1, presenilin 2. So ये सब तो basic information है. Now coming to the anatomical part that they want to ask is widespread cortical atrophy. Widespread cortical atrophy, especially hippocampus because memory is involved over here. Narrowing of gyri, widening of sulcus. This is important. Narrowing of gyri, widening of sulcus. Senile plaques, extracellular beta amyloid core may cause amyloid angiopathy, intracranial hemorrhage. So A beta synthesized by cleaving amyloid precursor protein. Now one important thing in this line, see, senile plaques जो होते हैं, okay, that is because of beta amyloid core. Now another thing I want you to remember कि Alzheimer's में amyloidosis होती है, okay. Amyloidosis occur in the Alzheimer's disease, and what is responsible for causing the this amyloidosis? So that is amyloid precursor protein APP, because you know amyloidosis के काफी सारे genes हैं, and every other disease are having different gene. Okay, so here it is amyloid precursor protein that is responsible for causing the amyloid plaques in the brain during the Alzheimer's disease. So mark this point. APP is seen in Alzheimer, that is responsible for amyloidosis. Okay, now another term, neurofibrillary tangles, intracellular hypophosphorylated tau protein. Okay, and Hirano body, intracellular eosinophilic proteinaceous rods in hippocampus. So all these are very important. Let's see how the senile plaques and neurofibrillary tangles are present. Okay, the letters are E and B, C, C. All this you will see. See, this is the normal one. This is one plaque. This is another plaque. This is what neurofibrillary tangles is. Okay, so all these images are very important, and neurofibrillary tangle I consider most important because in I got this in the exam. They showed the exact image like this. Okay, so coming back to our topic, Alzheimer's may coming to the anatomical part, you have to remember widespread cortical atrophy. Most commonly the plaques and everything will be seen in the hippocampus area. Okay, and the next is neurofibrillary tangles, and next is Hirano body. Hirano body they ask very less, but neurofibrillary tangles very important. And which gene is responsible for causing amyloidosis in Alzheimer's? That is APP. Okay, याद रखना APP. Don't select anything else. Now coming to frontotemporal dementia. Now see, if they want to ask you about the frontotemporal dementia, definitely they will say there is a personality change. Okay, there is a personality change. We saw yesterday in the frontal lobe, personality change. Frontal lobe is responsible for a personality change. Okay, so formerly called a Pick disease, early changes in personality and behavior. Okay, it can also have movement disorders. So inclusions of hyperphosphorylated tau, Pick bodies, or ubiquitinated TDP43. This line is very important. Okay. So frontotemporal dementia कैसे present होगा? Changes in the personality and behavior along with the movement disorder. It can be seen. Movement disorders can be seen, and it is dementia. So personality change के साथ memory भी affect हुआ है. Okay, and this is the pathological feature: inclusion of hyperphosphorylated tau or ubiquitinated TDP43. Okay, so these are one liners, and all the one important point that you have to remember in the neurodegenerative disorders. Next one is we saw the Lewy body dementia. Lewy body dementia में मैंने आपको बता ही दिया, Parkinson plus hallucinations is Lewy body dementia. Okay, now coming to the vascular dementia, इसका कोई particular case नहीं है, just one case. They will say that the person is hypertension or the person has atherosclerosis, history of atherosclerosis, and along with this he had a dementia. Okay, and in the radiology image, they will say MRI or CT shows multiple cortical infarct. Okay, so they will show this infarct to something related to the blood vessels, hypertension or atherosclerosis, and MRI and CT should show infarct in the brain or okay in the brain they will show something like. All right, so vascular dementia, very easy. Coming to Creutzfeldt-Jakob disease, it is also known as prion disease. Okay, it is also known as prion disease. So what is important over here is where it occurs, the spongiform cortex. This is very important. Second, prions beta pleated sheet resistant to proteases. This is second point. Now let's see what is given in the presentation. Rapidly progressive dementia. Okay, with myoclonus associated with periodic sharp waves on EEG and 1433 protein in CAS. 14cc protein in CSF. Okay, that's it. That's it. And it is very fatal. This line is very important, fatal, because all other neurodegenerative disease take time to become fatal. But Creutzfeldt-Jakob disease, that is a prion disease, it is very fatal within very short period of time. Okay. So what all three, 4 points that you need to remember here? Rapidly progressive dementia. Second is periodic sharp waves on EEG. Third, increase in 1433 protein in CSF, fatal, and spongiform cortex in the location, and prion disease. Okay, prions क्या होते हैं? Beta pleated sheet. All right. So this is what you need to remember for a Creutzfeldt-Jakob disease. HIV associated dementia. So they will first of all they will say that the presence of HIV. Okay, that's it. So this is what all you need to remember about neurodegenerative disorders. Mark my words, very high yield and again very easy. Very high yield and very easy. If you are able to pick out the symptoms, you are good to go with the information. Okay. So let's just move ahead. We have idiopathic intracranial hypertension. So this topic is important. Idiopathic intracranial hypertension, also called pseudotumor cerebri. Okay, and if they want to ask about what do we say? What is the most common risk factor causing this disease? The first answer will be vitamin A toxicity. Okay, like if they want to ask you about in terms of vitamin or nutrition, so vitamin A toxicity causes pseudotumor cerebri. Okay, so let's just see what all things are there. Increase in ICP with no obvious findings on imaging. Risk factors include female sex, tetracycline, obesity, vitamin A excess, danazol. These risk factors, you have to keep this in mind. Associated with sinus stenosis, the findings will be headache, tinnitus, diplopia, and the nerve, cranial nerve that will be responsible is cranial nerve 6. Okay, not 3 or 4 or anything. Cranial nerve 6 से diplopia होगा यहाँ पे. All right. There can be papilledema. And another thing you need to remember here is, yeah, lumbar puncture reveals increase in opening pressure and provides temporary headache relief. That's it. That you need to remember. If any of this condition is present, any of the drugs or risk factors are present, think about idiopathic intracranial hypertension. Okay, one or two questions are there in UL, so do it so you don't get it wrong. All right, coming to the hydrocephalus. See, NBME hasn't asked about hydrocephalus. Okay, NBME hasn't asked about hydrocephalus. UWorld has asked, and unfortunately, in my exam, one question popped up. Okay, exam में hydrocephalus के related one question came. So you have to do it. UWorld has 3 to 4 questions, I guess, but I didn't find anyone in NBME. Maybe it might be there in the old NBME, but new NBME, I hardly found one. But one or two questions are there, but they are not directly asking you the diagnosis of hydrocephalus. Okay, so make sure you do this. Exam में तो आया था. Okay, so first one, communicating and non-communicating. The first one we'll do communicating hydrocephalus. Decrease in CSF absorption by arachnoid granulation. Okay, ICP, papilledema, herniation. Before doing, before beginning ahead, sorry, going ahead, communicating hydrocephalus, I'll write it down for you. So you also write it down. Communicating hydrocephalus. headache, papilledema. Okay, dilation of all ventricles, uh, scarring after meningitis. Next, can cause herniation. Okay, so based on this information, if you look at the case, so what they will say: prior history of meningitis. Okay, papilledema in eye exam, and next one is enlarged ventricles on CT scan. Okay, this is how the case will be presented to you: history of meningitis, enlarged ventricles, and papilledema. Okay, so this you need to remember, and other lab values increase intracranial pressure. All right, so that is about the communicating hydrocephalus. Write it down if you want to. Okay, so yeah, one thing I wanted to add over here in the intracranial hypertension is, see here you have written tinnitus, right? So there is a type of tinnitus that is seen, that is pulsatile tinnitus. Now pulsatile tinnitus will be like, in the question they will give you rushing water and wind sound. Rushing water, yeah, wind sound. Okay, that is what known as pulsatile tinnitus. Okay, so question में ऐसे explain कर सकते हैं. And this is about the communicating hydrocephalus. Now next move towards the next type of hydrocephalus, that is normal pressure hydrocephalus, that is NPH, commonly written. Okay, NPH लिखा रहता है. Affects older adults, idiopathic. So CSF pressure elevated only episodically does not result in increased subarachnoid space volume, expansion of ventricles, distort the fibers of corona radiata. So here what you will be remembering is, you will be remembering expansion of ventricle. Here also the expansion of ventricles is happening. But what is the difference? There will be one triad: urinary incontinence, gait apraxia, and cognitive dysfunction. So ये triad होना चाहिए. Okay. मेनिंजाइटिस भी हो सकती है. प्रीवियस हिस्ट्री ऑफ मेनिंजाइटिस कैन बी प्रेजेंट हियर. ओके, पेपिलेडिमा कैन बी प्रेजेंट हियर, बट यू हैव टू फिगर आउट कि यूरिनरी इनकॉन्टिनेंस तो नहीं है, गेट एप्रेक्सिया तो नहीं है, एंड कॉग्निटिव डिसफंक्शन तो नहीं है. If you find these three features, your answer will be normal pressure hydrocephalus. All right. So wet, wobby, and wacky is the one funny term that you need to remember. And reversible with CSF drainage via lumbar puncture or shunt placement. Okay, so I hope you got the difference between NPH and communicating hydrocephalus. दोनों में symptoms same हो सकते हैं. Okay, symptoms can be same, history can be same, presentation can be same. One difference is triad. Okay, if in the hydrocephalus they are talking about urinary incontinence, think about normal pressure hydrocephalus. Okay, coming to non-communicating hydrocephalus, caused by the structural blockage of CSF circulation within ventricular system, stenosis of aqueduct of Sylvius. Okay, colloid says blocking foramen of Monroe. So these are all the CSF pathway. Okay, so how the CSF is formed from the electronic granulations and how it is everywhere going and circulating. So that is what these are the parts of CSF pathway. Okay, and if there is obstruction in this pathway, of course there is going to be the increase in the intracranial pressure, and as a result hydrocephalus can occur. So non-communicating hydrocephalus. Now we forgot this. This is about NPH, that is normal pressure hydrocephalus. See, this is what the dilation is they are showing. All the this is what the dilation they are showing. Okay, moving to the second. non-communication, you can see this is the ventricle and there is a blockage over here. Okay, so this is what non-communicating hydrocephalus looks like. All right, coming to the last type, and this is what was asked in the exam to me. Exam may I was asked about ex vacuo ventriculomegaly. Appearance of increase in CSF, but it's actually due to decrease in brain tissue and neuronal atrophy. They gave me the example of Alzheimer's disease, and then they asked me what else can be expected in this patient. In Alzheimer's also there is a widespread cortical atrophy. Here also there is a atrophy of the brain tissue. Okay. In exam they mentioned me there with the atrophy of brain tissue, but in Alzheimer's also we saw widespread atrophy of cortical tissue and brain. Okay, and increase in CSF and everything is given. But one thing that kept allowed me to diagnose it कि अल्जाइमर्स का तो ऑलरेडी डायग्नोसिस दिया हुआ है. They were asking me what other thing can occur. Okay, so increase in CSF pressure is given, so you can think about ex vacuo ventriculomegaly. So how to diagnose, how to remember this is आप examples याद रख लो. Huntington, frontotemporal dementia, advanced HIV and Alzheimer's. So all these are the neurodegenerative disease that you are seeing over here. Okay, ICP is normal and NPH triad is not seen, but means CSF pressure will be very high. Similar condition like the neurodegenerative disorders can also be presented. आपको बस दिमाग लगाना है कि इसके अलावा और क्या हो सकता है. Okay, this is what came to me. This is what was asked to me in the exam. Okay, so hydrocephalus I will mark it a high yield. No matter NBME में ज्यादा नहीं है, but UL में I think 3 to 4 questions तो आपको मिल ही जाएंगे. Okay, so that's it about hydrocephalus. And yeah, in the if they want to ask you about the non-communicating hydrocephalus, so in the UL they have given this presentation: enlarging head circumference. All right, NPH के बारे में not NPH, non-communicating hydrocephalus में they asked about enlarging head circumference. Okay, hydrocephalus very important, so clear it out. ज़्यादा डिटेल में भी नहीं जाना है, just remember 1 or 2 important points and you are good to go. Multiple sclerosis. Okay, तो मल्टीपल स्क्लेरोसिस में पैथोफिजियोलॉजी क्या है? ऑटो इम्यून इन्फ्लेमेशन एंड डीमाइलिनेशन ऑफ सीएनएस, ब्रेन एंड स्पाइनल सब्सिक्वेंट एक्सटर्नल डैमेज. डीमाइलिनेशन सिंड्रोम है of CNS. So can you tell me what type of cells are affected here? Come on, anyone? What type of brain cells are affected here? I need the answer. अरे बोलो.
Astrocytes, glial microglia.
Oligodendrocytes.
Yes, oligodendrocyte. They are talking about the demyelination of CNS. Oligodendrocytes are responsible for forming myelin sheaths in the CNS. And in PNS, what is responsible? Schwann cells.
Schwann
Okay.
cells.
Yeah. So this is the type of demyelinating disease. Okay. So you need to know कि अगर CNS है तो oligodendrocytes है. Multiple sclerosis CNS में demyelination कराता है and that is responsible for oligodendrocytes is responsible for this. Okay. So this is very important. So what all can be seen in the multiple sclerosis? How does case can be presented to you? Answer is optic neuritis हो सकती है. Brainstem cerebellar syndrome can occur. Pyramidal tract demyelination can occur, that is weakness, spasticity, etc. Spinal cord syndrome can occur. Okay. So see, basically कैसे आएगा is one simple question they always like to ask. In UL 3 to 4 questions are there with the same presentation. Symptoms after taking hot bath. Okay, so these symptoms are seen in the patient after taking a hot bath. Okay, this is the most commonly asked presentation in UL 3 to 4 questions are there, I think. In NBME also this same presentation was used, and in exam also the same will be used. Okay, so let's just see the symptoms. Optic neuritis, painful eye, brainstem or cerebellar symptom, anything related to cranial nerve or cerebellum disorganization can occur. Pyramidal tract demyelination, there can be weakness or spastic or flaccid paralysis. Spinal cord syndrome, All that will be discussing in spinal cord, like neurogenic bladder problem or a back problem, anything like that. Okay, or pain temperature problem and something like that. Anything can be present. Okay, so you have to keep this in mind. ये hot bath के बाद अगर ये सब symptoms दिख रहे हैं, it means multiple sclerosis is the diagnosis. Now let's see. We saw this hot bath exercise. Relapsing and remitting is the most common clinical cause. Relapsing and remitting. Relapse हो गया, again the symptoms are coming. Symptoms gone, symptoms coming back. Another point. Age okay, not needed. Okay, low vitamin D is important. Low vitamin D is important. Now let's see the lab value. Increase in IgG, myelin basic protein in CSF. Okay, क्योंकि demyelination तो रुका है, and inside that demyelination is occurring, so all the proteins of myelin will be deposited somewhere else because the myelin sheets are not forming. Okay, so ये सारी myelin protein जो है वो CSF में जाके accumulate हो जाएगी. Okay, all the myelin proteins will be accumulated in CSF because there is a demyelination going on. Okay, oligoclonal band aid is the diagnosis. These 3 points I am telling you, this is very important. Increase in IgE level, myelin basic protein in CSF, oligoclonal bands in diagnosis, and another one, periventricular plaques. Periventricular plaques, that is areas of oligodendrocyte loss and reactive gliocyte. This is also very important. Okay, so 4 things are important apart from clinical presentation: IgG, myelin basic protein in CSF, oligoclonal bands, periventricular plaque. And mark my words, they will directly give you in this question. Oligoclonal bands and periventricular plaques are seen in the bloodstream or in the CSF or in the brain or in the MRI or CT. They will directly give you this. Okay, UL में अगर आपने question solve किया है, you must have come across this. Okay, so these all are very important. Coming to treatment they don't usually ask, but let's just see. One thing you should be knowing is beta interferon, glatiramer, and natalizumab. That's it. Okay, that's it. And this is what they have given about summary. And see, this is the image you need to remember. This is what periventricular plaques look like. Periventricular plaque. Okay. All right. So this is all you need to remember about the multiple sclerosis. And one thing, yeah, one important thing that they have mentioned here, neurogenic bladder. Neurogenic bladder is very important in one of the NBMEs. Okay, in one of the NBMEs, they have asked, like what they asked was, they asked you to diagnose multiple sclerosis. They didn't give you a diagnosis. Okay, but they asked you to diagnose, and then in the options they gave what else can be associated with this condition. So neurogenic bladder is the most common, and answer was neurogenic bladder. All right, so neurogenic bladder is important. With this, we finish multiple sclerosis. Please don't forget multiple sclerosis demyelination syndrome, and it is associated with loss of oligodendrocytes because there is a demyelination in the central nervous system. Okay, let's move ahead. Now coming to other demyelinating and demyelinating disorders. Multiple sclerosis is a demyelinating disorder. Now these are other demyelinating disorders. And let's just see which are the important ones. Osmotic demyelination is important. Guillain-Barré syndrome is important. And Charcot-Marie-Tooth is important. These 3 very, very important. Okay, so let's just see what all are they. Also called central pontine myelinosis, massive axonal demyelination in pons. Okay, so this is the pons area. So pontine demyelination. If they ask about pontine demyelination, and if they give you this image, बीच में white white है और आजू बाजू पूरा black black है, this is what they are talking about, pontine demyelination. And the most common case that they will ask you over here is this: iatrogenic correction of hyponatremia, but also rapid shifts of other osmolyte, example glucose. Now correcting serum too fast. From low to high, your pons will die. From high to low, your brain. This is very high yield, and this is the only case they have I've seen asking. Okay, they have asked only this presentation for osmotic demyelination. Okay, they will say in the question his sodium level was rapidly corrected, or any other ion was rapidly infused or rapidly corrected. So this is what the reason for the central pontine demyelination. So always remember, ऐसा image आया या something they are saying कि rapidly corrected or rapidly infused. Think about this condition. And what happens is they are not giving the symptoms of this. Well, how they are asking is, what can be seen in this patient? What can be seen in this patient after rapid infusion of sodium? Okay, after rapid infusion of sodium, this is what they have asked. Okay, so you should be knowing osmotic demyelination syndrome. Another name is central pontine myelinosis. Okay, so that's it. You need to remember here. Moving down to acute inflammatory demyelinating polyneuropathy. Don't forget the name. What you do is you remember Guillain-Barré syndrome, but you don't remember what actually is the name. Acute inflammatory demyelinating polyneuropathy. Okay, so this is the name. So let's just see. Autoimmune condition that destroys the Schwann cells via inflammation and demyelination of motor fiber. Schwann cells है, so peripheral nervous system में दिक्कत आएगी. Peripheral nervous system में दिक्कत आई, so all the peripheral symptoms can be seen. Okay, so let's just see what is the problem here. All the cranial nerves from 3 to 12 they will be destroyed. Okay, उनके symptoms दिखेंगे आपको. And yeah, this line is very important. This is the biochemical line. Okay, facilitated by molecular mimicry and triggered by inoculation or stress. Facilitated by molecular mimicry is very important. Molecular mimicry. Wherever you hear the term molecular mimicry, one of the example is Guillain-Barré syndrome. Okay, mark it as a high yield क्योंकि बाद में याद नहीं रहेगा. Molecular mimicry, Guillain-Barré syndrome. Moving ahead. Infection. The most common infection is Campylobacter jejuni. You must have seen this in micro. Okay, and if you have done sketchy medical, you must have seen the images of 3 dogs or foxes that are there. Okay, so here ascending paralysis occurs. Can anyone tell me the meaning of ascending paralysis? Anyone?
Paralysis goes from downwards to the upside, like
Yes, yes, exactly. The paralysis first occurs in lower extremities, then it goes above. Okay, so नीचे से ऊपर it is ascending. Okay, sometimes there might not be paralysis in the upper limb, but lower limb definitely gone. The bladder, everything is paralyzed. Okay, so ascending paralysis is very important. Instead of ascending paralysis, they might explain you like this: the paralysis is seen in the lower part of the body, but is not seen in the upper part of the body, or the paralysis is seen in the bladder and the lower limb, but not in the upper limb, or paralysis was first seen in the lower limb, then it progressed towards the upper limb. So this is what known as ascending paralysis. Okay, so they have asked many questions like that. Now, facial paralysis can also be seen. And yes, one important point is respiratory failure is common. Respiratory failure is common. One question was there in the U world. They asked about the Guillain-Barré syndrome, and in the options they asked what you should look out for. So you should look out for the respiratory parameters also, because there will be respiratory failure over here. All right. Moving ahead, may see autonomic dysregulation also. Autonomic dysregulation, so cardiac disease, hypertension, all the sympathetic, parasympathetic symptoms will be gone. All right. And yeah, this is how you will make diagnosis. Increase in CSF protein with normal cell count, and this is what known as albuminocytologic dissociation. Increase in CSF protein with normal cell count, and where you will be confused is, where you will be confused. You will be confused when they ask you along with meningitis. Okay, meningitis में किसी किसी में प्रोटीन इंक्रीज होते हैं, वायरल में glucose and all those cells, and I will make you write it down. It's not given in first aid. I will make you write it down, the different types of meningitis: bacterial, fungal, viral, everything. Okay, so there you will be confused because brain का problem है. So most common brain problem you think about meningitis. Okay, so meningitis में भी there are different types ना, किसी में प्रोटीन ज्यादा है, ग्लूकोज ज्यादा है, सेल्स ज्यादा है. But in Guillain-Barré syndrome, what is happening is CSF protein is increasing, but normal cell count. Okay, so this you need to remember. and the treatment is IV immunoglobulin. IVIG is the treatment. So this is all that is you need to remember about the Guillain-Barré syndrome. They can ask you anything. Okay, and you can definitely 100% you can expect one question about GBS in the exam. One more thing, can anyone tell me Campylobacter jejuni जो है उसका डायरिया वाटरी है या ब्लडी? Anyone? Quickly tell me. Tell me Campylobacter jejuni का डायरिया वाटरी है ब्लडी? Anyone?
Bloody.
Yeah, so it is bloody. Okay. So they might also confuse you with this. A person went on a trek. He came back with a bloody diarrhea, and there was a paralysis in his lower limb, and later on it extended towards the upper limb. Respiratory depression was seen in the patient. What is your diagnosis? Okay. Or next question, what is seen in the CSF value? What is seen in the CSF? What is the lab value of CSF? Okay, so all these questions can be seen. Or third question, what is the pathophysiology of this condition? So you will say demyelination of Schwann cell or demyelination of peripheral nervous system. Okay, so 4 to 5 types of patterns. I told you how the questions will be asked in GBS. Okay, Guillain-Barré syndrome. That's it. So acute disseminated encephalomyelitis, they have not asked, so ignore it. Coming to Charcot-Marie tooth disease. Now see, Charcot-Marie tooth disease you can see as another disease, but only one clinical symptom you have to look out for and you are good to go. Let's just see. It is hereditary motor and sensory neuropathy. Okay, ये सब तो हो गया. Now one important thing that you need to remember here is autosomal dominant and it's associated with foot deformities. Example, pes cavus or hemato. Pes cavus or hemato, how the foot will be presented to you if this is the ankle, okay? This is the normal ankle. So if there is a pes cavus or hemato, na, the ankle will be like this, okay? If they are showing you the image of foot like this, think about Charcot-Marie tooth disease, okay? कहीं पे भी आया anywhere in this entire MBBS अगर food के related कुछ questions आ रहा है in the step 1 or NEET PG anywhere, think about Charcot-Marie tooth disease, okay? That's it. Moving on to the progressive multifocal leukoencephalopathy. This is high yield from the microbiome point of view, but let's do it here. Demyelination of CNS. It means again there is a problem in the oligodendrocytes. Okay, and this is what virus is responsible. JC virus. JC virus is responsible for causing this. Okay, so now see how the MRI is presented to you. सिर्फ ये ऊपर का पार्ट white white हो गया, बाकी सब normal है. Okay, so associated with severe immunosuppression and rapidly progressive fatal है, and it predominantly involves parietal and occipital lobe. So these 3-4 points are very important. Go back to the virus in JC virus infection. JC virus में देख लेना और क्या क्या होता है. I think kidney transplantation में भी JC virus का issue होता है. Okay, so they can give you a case of kidney transplantation, and along with that they will ask you about the demyelination. Okay, so everything you have to link it and everything you have to apply it and then solve it. Natalizumab is the drug. They never ask it, but कर लेना. Other disorders, Crab disease, metachromatic leukodystrophy, adrenal leukodystrophy. Crab disease हमने कहाँ पढ़ा था? Can anyone tell me what is the type of disease है Crab disease? Anyone? Quickly.
Lysosomal storage.
Yes, it is a liposomal storage disease. Okay, that's it for the demyelinating disorders. These are 3 to 4 types that you need to keep in mind along with multiple sclerosis. Multiple sclerosis को अलग से याद मत करना. Think it as a demyelinating disorder. All right, moving ahead, neurocutaneous disorders. Guys, एक बात याद रखना. If you are doing neurology perfect from first aid ना, perfect, अगर first aid से perfect कर दिया ना, I am guaranteeing you, if you give step 1, if you don't give step 1, no problem. If sudden change in the mind is, if there is sudden change in the plan, तो मुझे नीट पीजी देना है. If you do this first aid entirely very good ना, आपकी medicine हो गई है. Okay, just keep this in mind. You have already studied medicine. Okay, So because all these disorders that we are studying now, this is all a part of medicine. It is not taught in pathology. Okay, but US family is focusing on medicine from the very first 2-3 years. Okay, so इतना याद रखना कि आप अगर फर्स्ट ईयर कर रहे हो तो आपका लेवल बाकी सबसे हाई है. Okay, and that should be a confident booster for you. All right, coming back to our topic, neurocutaneous disorder. First one, Sturge-Weber syndrome. Sturge-Weber syndrome may one important highlight or one important point that will help you diagnose Sturge-Weber syndrome is Port Weinstein. Okay, Port Weinstein in the cranial nerve 5 distribution. Port Weinstein in the cranial nerve 5 distribution. Okay, ये एक important point है. If you get this or if you get the image like this, okay, ये okay, the image will be different in Port Weinstein. Okay, they will give you different boy or different girl. Port Weinstein in the cranial nerve 5, 1 and 2 distribution. Think about Sturge-Weber syndrome. What else is responsible? It is congenital, and this gene you need to remember. There will be leptomeningeal angioma with calcification. Leptomeningeal angioma. See calcification. Now another general rule of radiology. If you see, if this is a, this is your MRI or something like that you are seeing, and if you see something bright white ऐसे, it means calcification. Okay, it means calcification. इतना याद रखना. Calcification दिखता कैसे है, चाहे वो CT हो चाहे वो MRI हो, everywhere calcification will be like this bright white spot. Okay, so this is what you are seeing, leptomeningeal calcification. Okay, so I think that's what for the Sturge-Weber, and yeah, glaucoma can also occur. It is also called encephalotrigeminal angiomatosis. So sometimes instead of Sturge-Weber, they might give you this name. So the 3 points you need to remember: congenital and gene. Then you have Port Weinstein. Then you have leptomeningeal calcification on MRI, and next is glaucoma. Okay, and another term for Sturge-Weber syndrome is encephalotrigeminal angiomatosis. Okay, done with Sturge-Weber. Coming to tuberous sclerosis, autosomal dominant THC1, that is chromosome 9, THC2 is chromosome 16, hamartine and tuberin, very important. Coming to the features, hematomas in CNS, angiofibromas, mitral regurgitation, leaf spots, and renal angiomyolipoma and Sjogren patches. Everything is important. They will give you 2 to 3 presentation from this. And the most commonly they like to ask is leaf spot, renal angiomyolipoma. Okay, these two are very important. Mostly सारे questions में ये तो पूछते ही है. Okay, so increase in incidence of subependymal giant cell astrocytoma and angioma, ignore करो. But इतना याद रखो, wherever I have seen the questions of tuberous sclerosis, any two of these symptoms and they will ask you the gene. Okay, so देखते हैं कौन कौन सी बात यहाँ पे दी हुई है. C is angiofibromas. This is ash leaf spot, and this is what angiomyolipoma. Angiomyolipoma means fat भी है, fibers भी है, muscle भी है. तो fat है. I told you in the GIT class, if there is a fat in the biopsy, it is supposed to be white globules. Okay, this is general rule of pathology. अगर fat के बारे में कहीं पे भी आ रहा है, it means white will be present. Okay, so this is all about tuberous sclerosis. Moving to neurofibromatosis 1. Neurofibromatosis 1 में autosomal dominant NF1 chromosome 17. You have to remember. Negative RAS regulator is also important. Okay, coming to the symptoms, cafe or light spots, cutaneous neurofibromas, Lisch nodules. Lisch nodules very important. Pheochromocytoma very important. Okay, also called von Reckling-Gonson disease. Von Reckling-Gonson, they have asked in the exam. Instead of neurofibromatosis 1, they ask von Reckling-Gonson disease. Okay, so let's just see इसमें क्या क्या दिखता है. Cafe loud spot, neurofibromas cutaneous वाले, and Lisch nodule. And remember my word, this pheochromocytoma and Lisch nodules, they are very important. Okay, pheochromocytoma, why? Because it is occurring in many other conditions. So you will be confused if pheochromocytoma दिया है तो neurofibromatosis होगी कि नहीं होगी. Okay, and if they want to give you the image will be like this. Okay, this is a very normal neurofibromatosis. Okay, if you see the neurofibromatosis image, it is very bad to see. बहुत दया आता है देख के. So पूरा बैक में आपको फिब्रोमा दिखेगा. Okay, so this is what about neurofibromatosis 1. You have to remember about pheochromocytoma. In neurofibromatosis 2, pheochromocytoma is not there. Okay, so this is one distinguishing feature. अगर आपको बाकी कुछ याद नहीं आ रहा है तो. Coming to neurofibromatosis 2, autosomal dominant tumor suppressor gene Merlin on chromosome 22, bilateral vestibular schwannoma. This is very very important. Meningiomas, एपेंडाइमोमा. सो इफ दे आस्क यू कि ब्रेन ट्यूमर के साथ कौन से न्यूरोक्यूटेनियस डिसऑर्डर्स है, योर आंसर विल बी न्यूरोफिब्रोमाटोसिस 2. ओके, ब्रेन ट्यूमर, मेनिंजियोमा, एपेंडाइमोमा, वेस्टिबुलर स्क्वानोमा, these are all brain tumors. Okay, so 1 and 2 you should be knowing the gene and you should be knowing the clinical presentation. All right, moving to the last type, von Hippel-Lindau disease, VHL gene, ubiquitinous hypoxia inducible factor 1A, Hemangioblastoma is very important. Hemangioblastoma is very important. Where it is seen, spine, cerebellum, retina, everywhere. Angiomatosis, bilateral renal cell carcinoma is very important. Bilateral renal cell carcinoma. Again, pheochromocytoma. Okay, so pheochromocytoma में NF1 and VHL. You both have to remember this. Okay, so this is what hemangioblastoma looks like. And another thing is, this is what the image for hemangioblastoma is. This they haven't asked frequently, so you can leave this, but this image they have asked frequently. Okay, so one two word is what is helping you to diagnose and differential diagnose it. Okay, एक बात याद रखना, pheochromocytoma का most commonly they ask which neurocutaneous disorder. Second thing, they ask renal cell carcinoma किस में दिखता है, so von Hippel-Lindau disease. Okay, and another they most commonly ask this list nodules, Caffeal outspot, S-leaf spot, and renal angiomyolipoma. Okay, so all these things are very important. Presentations आपको जितनी बार questions करोगे, you will be familiar with those. And yes, genes you have to remember. Remembering the genes, there is no shortcut. You have to try to remember it. So with this, we are done with the neurocutaneous disorders. Coming to brain tumors, another very high yield. Everything is high yield in neuro. Okay, everything is high yield, and mark my words, neuro is very easily diagnosed हो सकता है. Neuro is a score booster. आपको difficult इसलिए लग रहा होगा because it is very big, so much of information to grasp. Okay, but as I told you yesterday, if I can do, so you can also do. So let's just start with the primary brain tumor, glioblastoma. नाम से ही दिख रहा है, so there will be increase in astrocytes over here. And yesterday we saw the astrocyte का marker कौन सा है, GFAP. So let's just see, वही दिया हुआ है इधर, astrocyte GFAP positive. Okay, so आपका ये तो हो ही गया. Now let's see what extra information is given over here. Extra information is it is grade 4 ectocytoma. Actually, yeah, ectocytoma के 4 grades होते हैं, and the grade 4 is the worst prognosis वाला. Okay, so glioblastoma multiforme में जो होता है वो इसमें होता है. एक मिनट. Yeah, the full name of this is glioblastoma multiforme. Okay, so don't get confused. GBM भी बोलते हैं इसको. Okay, malignant brain tumor, it is a malignant found in cerebral hemispheres. Okay, it is seen in the cerebrum, and that is the butterfly glioma. Okay, let's just see. And yeah, one important point is associated with EGFR amplification. इसमें देख लेते हैं pseudopalisading pleomorphic tumor cell. Okay, it is pseudopalisading over here. So guys, tell me palisading हमने कहाँ देखा था? Can anyone try to recollect? We saw palisading in the tumor. What was that tumor? Please someone tell me. जिसने बता दिया उसकी प्रिपरेशन अच्छी जाती है. Come on, याद करो, palisading न्यूक्लियाई कहाँ पे देखी थी हमने? It is not a neuro. One hint for you.
Is it an endo?
Nope. एंडो में भी है, बट एंडो वाला कॉमनली नहीं पूछता. अनदर वन ट्राई टू रिकलेक्ट. सारे सिस्टम देखो, ट्यूमर याद करो, कहाँ पे था पेलिसिडिंग न्यूक्लियाई. कम ऑन शेरिन, ट्राई टू रिकलेक्ट. कम ऑन. नहीं याद आ रहा? बेजल सेल कार्सिनोमा ऑफ स्किन, याद आया? पैलिसेडिंग न्यूक्लियाई.
Yeah.
ओके, दैट इज द मोस्ट कॉमनली आस्क्ड एग्जाम. सो बेजल सेल कार्सिनोमा ऑफ स्किन में भी आप ये कर सकते हो. ऐसे ही याद करना है भाई, एग्जाम में ऐसे ही आएगा. ओके, सो लेट्स जस्ट सी border central areas of necrosis, hemorrhagic or microvascular proliferation. This line is very important. See, in the brain tumors, na, one line is going to help you to make the diagnosis because the presentation will be similar in all of them. Okay, presentation सब में same होगा. So what we do if you are confused now, make some, for example, glioblastoma है, तो glioblastoma लिखो और उसके साथ ये line लिखो pathology की. Okay, because in the exam pathology pathology दिया रहेगा. You have to identify where is this pathology seen. Okay, so for glioblastoma, this is the pathology: border central areas of necrosis, hemorrhage or macrovascular proliferation. Okay, and this associated with EGFR amplification. ये पुराने एडिशन में नहीं दिया है, but it was asked in NBME, so they have added it over here. Okay, तो glioblastoma का butterfly lesion देख लेते हैं. This is what glioblastoma looks like. This is what pseudophagocytosis looks like. Okay. So this is what about glioblastoma. Let's move to the oligodendroglioma. Relatively rare, slow growing, most often in the frontal lobe, often calcified. Okay, fried egg cells, round nuclei with clear cytoplasm. So this is your pathology for oligodendroglioma. Fried egg cells, round nuclei with clear cytoplasm. ये एक लाइन है that will help you diagnose oligodendroglioma. Okay, chicken wire capillary pattern. Chicken wire capillary pattern is also very important. ओके, आओ देखते हैं कैसा दिया है. फ्रंटल लोब में था. ऑलराइट, एंड दिस इज व्हाट चिकन वायर पैटर्न लुक्स लाइक. ओके, इमेजेस याद कर लेना. 99% सेम इमेज आएगा एग्जाम में. ओके, तो oligodendroglioma, this is the pathology line. In glioblastoma, this is the pathology line. Coming to meningioma, common, typically benign, females में ज्यादा, extra axial, external to brain parenchyma, and may have a dural attachment. So here there will be dural tail present. Okay, in the exam they will give you dural tail. So if there is a dural tail, don't get confused. Let me see the image. Image में dural tail दिया है कि नहीं दिया तो मैं बना के दिखा दूंगा आपको. Okay, it may be present with seizures. तो seizures अगर आ रहा है तो most commonly think about meningioma. And we did the neurocutaneous disorders. Meningioma किसके साथ था? Neurofibromatosis 2. Okay, so arachnoid cell origin. Spindle cells concentrically arranged in a whorled pattern. Samoma body. So this is your pathology. Okay guys, this pathology is very important. हो सकता है they might not show you the MRI. हो सकता है they might not show you the histology. They will directly give you the one line of pathology and you should be picking that out. Okay, so one line, one pathological line, very important. Okay, how meningioma देखते हैं. See, here they have not given about the dural tail. Let me see here ना. Yeah, yeah, they haven't given the dural tail. So अगर dural tail exam में पूछना है, so what they will do is, so this is how dural tail looks like. Okay, इसमें dural tail नहीं दिया है. This is just given a tumor over here, but dural tail is not given. So अगर dural tail आया तो ऐसे end में tail shape दिखेगा. That is the diagnosis for meningioma. Okay, and you can see पूरा whorled pattern है, पूरा whorled, इधर से mix, उधर से mix, इधर से mix, इधर से mix, everything. So this is what the diagnosis for meningioma. All right, moving ahead, we have hemangioblastoma. Most often cerebellar, associated with von Hippel-Lindau syndrome we saw ahead, can produce erythropoietin. The only tumor that is producing erythropoietin, hemangioblastoma. Okay, blood vessel origin, closely arranged, thin wall capillaries with minimal interpreting parenchyma. Guys, this line is also important. NBME ने पूछा है. Thin walled capillaries with minimal intervening parenchyma. Okay, आओ देखते हैं कैसे दिखता है. This is what hemangioblastoma, hemangioma or hemangioblastoma, whatever you can say, and this is what thin wall capillaries of looks like. Okay, बाकी सबसे अलग, ये सबसे अलग दिख रहा है hemangioma. All right, hemangioblastoma. Sorry. Coming to pituitary adenoma, now the most common pituitary adenoma will be of prolactinoma. ओके अगर प्रोलैक्टिनोमा है तो आपका GnRH कम हो जाएगा. So this is how they will be presenting the case to you. Case कैसा आएगा? Decrease in libido, decrease in spermatogenesis, decrease in sperm count, decrease in everything related to GnRH. Gonadotropin releasing की सारी function decrease हो जाएगी. Okay. Another most common feature they like to ask is bitemporal hemianopia. Bitemporal hemianopia. Now how the question is asked in bitemporal hemianopia, ये आपकी दो आंखें हैं, तो यहाँ की विजन गई, यहाँ की विजन गई. Bitemporal hemianopia, साइड विजन नहीं दिख रही, peripheral vision loss, and in the exam they will give you this. Okay, एग्जाम में कैसे देंगे? आपको एक सिटी का इमेज दे देंगे, फॉर एग्जाम्पल न्यूयॉर्क सिटी, एंड दे विल डिवाइड द आई, एंड साइड से जो होंगे ना वो ब्लर दिखेगा, एंड मिडल से इट विल बी clear. That is what known as bitemporal hemianopia. Or else they will say the patient is not able to look or in the periphery. Patient is not having the peripheral vision. That is bitemporal hemianopia. Okay. So bitemporal hemianopia becomes very important, and prolactinoma is the most common. उसकी वजह से GnRH decrease हो जाएगा. Okay. So I have already told you all the important things that you have to remember here. And इसका ट्रीटमेंट पूछते हैं. So what you will, अगर प्रोलैक्टिन इंक्रीज हो रहा है आपका, तो आप क्या दोगे? डोपामिन. ओके, प्रोलैक्टिन इंक्रीज हो रहा है तो डोपामिन दोगे, इट विल डिक्रीज प्रोलैक्टिन. So dopamine antagonist, that is bromocriptine and all those stuff. Okay, that's it you need to remember for pituitary adenoma. Another thing, प्रोलैक्टिन इंक्रीज हो रहा है. ओके, तो मिल्क प्रोडक्शन भी कहीं ना कहीं इंक्रीज होगा. सो एज अ रिजल्ट मोस्ट कॉमनली लैक्टोट्रॉप इंक्रीज हो जाएंगे. व्हाट टाइप ऑफ सेल्स आर इंक्रीज इन पिट्यूटरी एडिनोमा? लैक्टोट्रॉप. ओके, तो ये सब आपको याद होना चाहिए. दिस इज ऑल अबाउट द एंडोक्राइन बेसिक्स. ओके, पिट्यूटरी एडिनोमा डन. कमिंग टू स्क्वानोमा. Basically at the cerebellopontine angle, they will give you definitely this word, cerebellopontine angle, involving 5, 7 and 8 nerves. This is very important. Okay, and another thing is, yeah, bivascular schwannoma कहाँ देखा था हमने? NF2. So it is associated with NF2, neofibril metastasis 2. Okay, and this is what the lab values will be giving you. Schwann cell origin S100 plus, biphasic dense hypercellular areas containing spindle cells alternating with hypocellular myxoid area. This is the pathology. Okay, this is the pathology for schwannoma. Okay, guys, I am telling you again, pathology याद करके जाना, रट के जाना. They might not show you the histology, they might not show you the image, but pathology definitely will be there. Or else they will give you the diagnosis, you will be asked for the pathology. Okay, so pathology रट के जाना, एक पेज में लिख दो, लिखना हो तो. So that's all for schwannoma. Moving ahead. So देखो, this is what bitemporal hemianopia is. This is what the pituitary adenoma is. This is see cerebellopontine angle. This is cerebellopontine angle और यहाँ पे ट्यूमर है. Okay, and this is what myxoid appearance. Okay, pituitary adenoma आपको identify करने आना चाहिए. Yesterday I sent you the images. In one of the images there was a pituitary gland also. Okay, so try to identify the pituitary gland and try to identify the tumor if they are asked. Okay, so last page for the brain tumors. Pilocytic astrocytoma. Okay, so low grade astrocytoma. यहाँ पे भी सेम मार्कर होंगे, astrocyte GFAP positive. Okay, so associated with microcysts and rodental fibers. तो ये आपकी पैथोलॉजी इधर हो गई. Okay, in children most often found in posterior fossa, good prognosis. Okay, तो देखते हैं ये रहा इमेज. सी इसमें ना दे वोंट आज द इमेज. पिलोसाइटिक एस्ट्रोसाइटोमा में इमेज नहीं पूछते, डायग्नोसिस भी नहीं पूछते, वो लोग डायरेक्ट ये लाइन दे देंगे. दे विल से इट इज ऑफ एस्ट्रोसाइट ओरिजिन एंड दे विल गिव यू दिस लाइन. ओके, rodental fibers are pilocytic astrocytoma. All right, coming to medulloblastoma, most common malignant brain tumor in childhood, commonly involves cerebellum, can compress fourth ventricle causing non-communicating hydrocephalus. So hydrocephalus becomes important over here, non-communicating wala. Okay, can involve cerebellar wormis, truncal ataxia, form of primitive neuroectodermal tumor on a right rosette. So this is the pathology over here. Okay, so यहाँ पे most commonly they ask you with this presentation, ataxia plus this pathology. Okay, ataxia plus this pathology, medulloblastoma. ओके, देख लेते हैं कैसा है, cerebellum में इंक्लूड हो रहा है. एंड दिस इज व्हाट रोजेट लुक्स लाइक, रोजेट लाइक अपीयरेंस लुक्स लाइक, स्यूडो रोजेट. ओके, रोजेट कैसे दिखते हैं? रोजेट ऐसे दिखते हैं. ओके, see these are a few common pathological terms that you need to be aware about. Okay, rogettes ऐसे दिखते हैं. And it is they are asking about pseudo rogettes. This is the answer. Okay, these are the rodental fibers. All right, so let's move ahead. मैंने गड़बड़ कर दी, ये pseudo rogettes नहीं है, ये rogettes ही है. Pseudo rogettes दिख रहे हैं एपेंडाइमोमा में. Okay, sorry, my mistake. Pseudo rogettes are seen in the ependymoma. This is rogettes only. All right, moving to ependymoma. Now, if they are asking you about ependymoma, na, they will give you decrease in CSF production. कहीं पे तो देंगे वो लोग, डिक्रीज इन CSF प्रोडक्शन फोर्थ वेंट्रिकल के आसपास हो रहा है. ओके, एंड हियर एपेंडाइमल सेल ओरिजिन कैरेक्टरिस्टिक पेरिवास्कुलर pseudorodget rod shaped blepharoplast. This is the pathology. Okay, if they want to ask you about ependymoma, they will definitely tell you decrease in CSF production. Okay, ये रहा इसका इमेज, ये CSF पाथवे पे है और ये रहा इसका इमेज. ऑलराइट, मूविंग टू क्रेनियोफेरेंजियोमा. क्रेनियोफेरेंजियोमा इज सिमिलर टू पिट्यूटरी एडिनोमा. ओके, पिट्यूटरी एडिनोमा के सिमिलर है, बस एक डिफरेंस है. Calcification is common and cholesterol crystals are found that gives a motor oil like appearance derived from remnants of rat pulp. तो यहाँ पे ये इंपॉर्टेंट है, बाकी सब कुछ पिट्यूटरी एडिनोमा के हिसाब से होगा. ओके, एंड pineal gland tumors. Okay, most commonly extracorneal germ cell tumors, males present with obstructive hydrocephalus. ये भी याद करने के लिए. One important point that you need to remember here is Parinov syndrome, that is a triad of upward gaze, convergent retraction, nystagmus and light near addition. See, बेसिकली इसमें से कुछ भी याद मत करो, एग्जाम में कभी पूछा नहीं है. ओके, कुछ भी पूछा नहीं है. वन थिंग आई एम सेइंग, हियर आल्सो दे विल इंक्रीज इन एरिथ्रोपोइटिन. Okay, so if they ask you a tumor in child which is increasing erythropoietin, answer is pineal gland tumor. Directly पूछ लेंगे आप. Okay, this is what the tumor looks like. All right, so देखो brain tumor बहुत important है, very important. They are not asking you about any treatment. They are not asking you about any surgery. They are just asking you to remember pathology and symptoms. Symptoms भी काफी कम पूछ रहे हैं. Remember the MRI image, remember the histological slide, and then remember the pathology. Okay, these three things अगर आपने अच्छे से कर ली, you're good to go for the exam. Okay, just remember one word from that line also ना, you are good to go. Rogers किस में, rodental fibers किस में. फिर आगे जाके हमने देखा ये थिन कैपिलरी वाले किस में है, fried egg, that is chicken cell, chicken wire appearance किस में. Just one word is important for you. Okay, so with this we are done with tumors. Let's move on to the herniation syndrome. Herniation syndrome में ना, they won't ask you this one. यूवर्ल्ड में एक क्वेश्चन है खाली, एनबीएमई में एक भी नहीं है इन विच दे हैव आस्क्ड यू अबाउट दिस. सिर्फ अंकल हर्निएशन का पूछा है. अंकल हर्निएशन इज इंपॉर्टेंट. हाउ यू विल आइडेंटिफाई दैट द पेशेंट इज टॉकिंग, क्वेश्चन इज टॉकिंग अबाउट अंकल हर्निएशन इज unilateral cranial nerve 3 compression. So if there is a cranial nerve 3 compression, how the pupil will look like? Pupil will be down and blown. Okay, ipsilateral blown pupil. Pupil will be down and out. So that is what cranial nerve 3 palsy looks like. And if they give you something else along with this cranial nerve 3 palsy, you can think about uncal transcentral herniation. That's it. All right. So next is spinal cord syndrome. Let's take a 5-minute break. And उसके बाद spinal cord and meningitis, eye and farm ये complete करते हैं. Okay, today we'll finish it most probably. So let's take a 5-minute break and वापस मिलते हैं. All right, then we can begin. So before starting the spinal cord syndrome, let's just look out at the spinal cord anatomy. All right. So this diagram is very important. See, because sometimes what they ask is they will ask you the various regions of spinal cord. Okay, this is also the important diagram. Based on this location, you have to identify the parts over here in spinal cord. Okay, now they will ask you what part is associated with what. Okay, this you have to remember: ascending limb, lateral spinal thalamic tract, anterior spinal thalamic tract, dorsal column का function क्या है, lateral corticospinal tract ये सबका function क्या है. Okay, you should know कि ये part में क्या है, ये part में क्या. Okay, you should know this because the questions have been asked. They will ask you the disorders of spinal cord, or what they will say is they will give you that the patient is not able to feel this. They is not able to feel pain in temperature. Pain in temperature. He is not able to feel what do we say, proprioception or vibration or something like that. Okay, they will give you like this, and in the question they will ask you which of the following location is responsible for this. Okay, so you should know कि dorsal column इधर है. You should know कि spinal thalamic tract lateral वाला इधर है, anterior वाला इधर है. You should know cortical spinal tract इधर है और lateral वाला इधर है. Okay, so you should be knowing the diagram. You should be knowing the functions and everything. Functions will be discussing here, but बाकी सब तो आपको पता होना ही चाहिए along with the diagram. So let's just see what all you need to remember. Fasciculus gracilis and fasciculus cunatus. Gracilis lower limb, cunatus upper limb. Okay. Dorsal column किसके लिए है? Pressure, vibration, fine touch. Okay. Coming to ascending tract, उसमें lateral spinothalamic tract, pain, temperature. Anterior spinothalamic tract is for crude touch and pressure. Each and every function is important. Okay. आपको functions अच्छे से आने चाहिए. Coming to descending tracts, we have lateral corticospinal tract and anterior corticospinal tract. Okay, lateral corticospinal tract voluntary motor, anterior भी voluntary motor है. तो इसमें corticospinal tract आया तो motor symptoms के related होगा. Okay, so this is what I was saying. You should be knowing each and every region of spinal cord. Label करना आना चाहिए. Keep this image as a reference and practice identifying over here. Okay. सेम इमेज आपको आएगा एग्जाम में, इवन इन एनबीएमई. ओके, यूवल ने तो ऐसे भी पूछा है, ऐसे भी पूछा है. ओके, सो यू शुड बी नोइंग द वेरियस लोकेशन ऑफ वेरियस ट्रैक्स इन द स्पाइनल कॉर्ड. सो लेट्स कम टू द functions. Spinothalamic and dorsal column, synapse and then cross. Corticospinal tract crosses and then synapse. Okay, so this is one important line. Now, ओके, तो डॉर्सल कॉलम का पहले डॉर्सल कॉलम देख लेते हैं. ओके, फंक्शन pressure, vibration, fine touch, proprioception. Okay, and what else you need to remember? Nucleus gracilis and nucleus spinatus you have to remember. Decussate in medulla, ascend contralaterally at the medial lemnical. Okay, so the lesions will be contralateral. Right में problem है तो left में दिक्कत होगी. So it is contralateral. Coming to spinothalamic tract, pain, temperature. Okay, posterior synapse decussate in the spinal cord at the anterior wide commissure, ascends contralaterally. Okay, contralateral यहाँ पे भी. Coming to corticospinal, voluntary movement, anterior horn, element leaves spinal cord. I think जो corticospinal tract का जो है ना, वो शायद ipsilateral होगा, शायद. The lesions will be ipsilateral for corticospinal tract. Okay, but corticospinal is not most commonly asked in the exam. ओके, बहुत रेयर पूछते हैं इफ दे आर टॉकिंग अबाउट वॉलंटरी मोटर मूवमेंट. ओके, वॉलंटरी मोटर मूवमेंट बोलेंगे only then you will think about corticospinal, whereas they will confuse you with spinothalamic and dorsal column. Spinothalamic maybe they will confuse you with lateral and anterior, and dorsal column maybe will confuse you with gracilis or cuneatus. Okay, so इसमें ना UL में they have asked one arrow questions also. Pain, temperature, proprioception, vibration, everything they have given. and then they will say कि इधर problem हुआ है, in this region of spinal cord there is a problem, what will increase, what will decrease. So you know कि this region of spinal cord is responsible for this problem. Okay, so I would repeat again, functions याद करो और ये diagram को अच्छे से रट डालो, practice yourself by keeping this as a reference. Okay, एक बार diagram से ये आपको अच्छे से आ गया ना, you will expel in spinal cord disease. Okay, so let's just come to the pathology of spinal cord. All right. First one, spinal muscular atrophy. Guys, try to look at the location देखते जाना. Okay, spinal muscular atrophy, congenital degeneration of anterior horn. Okay, anterior horn का degeneration हुआ है. Element before that let's just see UMN and element lesion. Okay, upper motor lesions में the activity is going to be high. अब मतलब बहुत ज्यादा एक्टिविटी होगी, हाइपर रिएक्टिविटी, वेरी स्ट्रॉन्ग रिफ्लेक्स, स्पैस्टिक पैरालिसिस. ओके, तो ये सब चीजें आपको याद रखनी है. दिस रिफ्लेक्सेस विल बी इंक्रीज, टोन विल बी इंक्रीज. बबिन्स की पॉजिटिव, बबिन्स की टेस्ट यू ऑल नो, जो एक कुछ प्लेट लेते हैं, उसको टोस्ट पे ऐसे प्लांटर पे मारते हैं, ऐसे रब करते हैं, तो उससे टोस्ट का ऐसा रिफ्लेक्स दिखता है. ओके, so that is what known as Babinski reflex. So spastic paralysis and class night spasticity and weakness. Okay, so this is all important कि आपको differences पता होना चाहिए कि whether they are talking about upper motor lesion or lower motor lesion. If you are not able to distinguish whether they are upper motor or lower motor, you will fail in spinal cord syndrome. Okay, because spinal cord syndrome में कुछ चीजें ऐसी है जो upper motor करती है और कुछ lower motor करती है. You should be able to identify कि they are talking about upper or lower, and based on that you will make the diagnosis. Okay, so let's just see spinal muscular atrophy. So spinal muscular atrophy may we saw it is a lower motor symptom. Okay, so floppy baby syndrome, hypotonia hoga, tone decrease hoga because it's lower motor. It is autosomal recessive. Okay, and the defective SNRNP assembly. SNRNP assembly, we saw this along with the splicing. Okay, splicing part in the biochemistry. Okay, SNRP, signal recognition peptide wala. Okay, so it is also called Werning-Hoffman disease. Not frequently asked, but you know they have asked about the floppy baby syndrome. So floppy baby syndrome hai, so remember two things: lower motor neuron, another name Werning-Hoffman disease, and another thing is what is another thing? Autosomal recessive and this gene. Okay, नाम तो आपको याद रखना है, spinal muscular atrophy, and the 3 points you have to remember because floppy baby syndrome exam में आया है and it was asked to me in the exam. Okay, but again not commonly asked. NBME में I think एक क्वेश्चन होगा, UL में एक क्वेश्चन होगा, ज्यादा नहीं होगा. Coming to amyotrophic lateral sclerosis, one extra information here, Stephen Hawking was a patient of ALS. Okay, just extra information, they never asked. तो ये आपका डायग्राम है, you should see lesions कहाँ पे है. Okay, so अभी देखते हैं. Also called Lou Gehrig disease, combined UMN and LMN. Okay, combined UMN and LMN, यहाँ पे आप ये ब्रैकेट में जो है वो अवॉइड कर सकते हो because it becomes very confusing. Okay, we don't have to remember all the tracks of spinal cord. If we try to remember all the tracks, if your memory power is very good, it's good for you. But if it is average, छोड़ दो. वो स्पाइनल कॉर्ड के जितने भी ट्रैक्स है सारे याद करने की जरूरत नहीं है. ओके, सो ये छोड़ दो. जस्ट रिमेंबर कि यूएमएन प्लस एलएमएन लीजन, most common disorder they ask is ALS, amyotrophic lateral sclerosis. Okay, so there will be no bladder involvement, बिल्कुल नहीं होगी. Okay, can be caused by defect in the superoxide dismutase. Okay, so element deficit है तो हमने आगे देख ही लिया, flaccid limb, bulbar palsy में यूएमएन डेफिसिट भी है तो स्पैस्टिक लिम्ब, हाइपर रिफ्लेक्सिया सब आएगा. ओके, ट्रीटमेंट पूछते हैं राइलोजोल. ओके, सी गाइस, स्पाइनल कॉर्ड सिंड्रोम थोड़ा डिफिकल्ट होता है डायग्नोस करना बिकॉज यू हैव टू प्ले विद द ट्रैक्स आल्सो ओवर हियर, डोर्सल कॉलम, स्पाइनोथैलेमिक ट्रैक एंड एवरीथिंग. ओके उसके बाद यू हैव टू प्ले विथ यूएमएन एंड एलएमएन. ओके उसके बाद यू हैव टू प्ले विथ द जनरल इंफॉर्मेशन. तो स्पाइनल कॉर्ड के जो भी सिम्टम्स है, सिंड्रोम्स है, दे आई फील देम लिटिल डिफिकल्ट. सो व्हाइल सॉल्विंग द क्वेश्चन पे प्रॉपर अटेंशन कि आप क्या सोच के कर रहे हो और यूवर्ल्ड में भी वही सोच के किया कि नहीं. ओके so just do this properly. SMA was only about LMN. ALS is about UMN and LMN both. Okay. Coming to complete occlusion of anterior spinal artery, ASA. So it spares dorsal column and leisure track. Leisure track आप छोड़ सकते हो, but इतना याद रखना कि dorsal column will be normal. Dorsal column will be normal है मतलब proprioception, vibration, pressure, fine touch, everything will be working properly. Okay. Only that kit you need to remember. And yes, loss of pain and temperature sensation below the lesion. Pain and temperature क्योंकि spinal column track गया हुआ है. Only dorsal pain, dorsal column is remaining there. Okay, so ये आपको ऐसे याद रखना है. Coming to tabes dorsalis syphilis की वजह से होता है tertiary syphilis, and in tabes dorsalis the dorsal column is affected. So if dorsal column is affected, there will be defect in vibration, proprioception, pressure, everything. But pain and temperature will be normal. Okay, so this is how you will be making the diagnosis based on the tracks. Okay, so let's just see caused by tertiary syphilis and demyelination of dorsal column, and another thing is Romberg positive, Charcot joint. सारे ये आपके आ जाएंगे syphilis के characteristics. Okay, but remember one thing, dorsal column उड़ गए हैं मतलब proprioception, pressure, vibration सब जाएगा. Okay, coming to syringomyelia, very important. So many questions are there in UL and in NBME also. So syringe expands and damages the entry-wide commissure of spinothalamic tracts. So bilateral symmetric loss of pain and temperature in cape-like distribution. Okay, तो ये मैंने आपको बताया था. If in the exam they give you the spinal cord का radiological image, okay, अगर spinal cord का radiological image था मैंने आपको बताया था ऐसे आपको दे दिया और बीच में and in between there is this white spot that you are seeing. Think about syringomyelia because what is happening here is syringe is expanding. So expanding की वजह से वो right white ऐसा गोला दिखता है बीच में. Okay, and what tract is affected here is spinothalamic tract. Okay, spinothalamic tract affect हो गया तो क्या होगा? Pain and temperature will be gone, and it is bilateral. Okay, remember it is bilateral. Coming to B12 deficiency, you know the tracks, corticospinal tract, dorsal column tract, spinocerebellar tract. तो ये आपका लोकेशन ये हो गया. अब B12 deficiency है, so you know what else can be there? Megaloblastic anemia, and you know the lab values and everything. Okay. Coming to Cauda equina syndrome, and if in the spinal cord disorder they are talking about the bladder problem, this is the answer. Okay. Bladder problem के बारे में पूछ रहे हैं spinal cord के साथ साथ. Cauda equina is the answer. So radicular pain, absent knee and ankle reflex, loss of bladder. क्योंकि bladder के साथ साथ knee and ankle reflex सारे affect हो जाएंगे. Okay. So this is one line. I am repeating again, and now I will be telling you how the questions will be asked. Okay. SMA में कुछ नहीं याद करना है. SMA में फ्लॉपी बेबी सिंड्रोम याद करना है. That's it. ALS इंपॉर्टेंट है और इसमें क्लासिक केस में आपको बता देता हूँ कि एग्जाम में कैसे आएगा. हाउ इन द एग्जाम दे विल आस्क यू 50-year-old slowly progressing arm weakness, dysphagia, some muscles are flaccid, some spastic, and no bladder involvement. Okay, so some muscles are having very high tone and some muscles are very flaccid. Okay, so ऐसे हो सकता है. तो स्टीफन हॉकिंग को जो था उसके मोस्टली फ्लैचिड थे, फेस के थोड़े मसल्स स्पास्टिक थे. Okay, that's why he was always on the chair. He wasn't able to move them because the muscles were very floppy. Muscles floppy हो जाएंगे तो you won't be able to even pick up. एकदम फ्लैचिड हो गए तो कोई एकदम ऐसा लगता है कि पानी का पाउच भरा पड़ा है. Okay, so this is what a classic case of ALS will be given to you. 50-year-old dysphagia होगा and some will be spastic, some will be flaccid. Instead of using this term, they will give you some muscles are having very high tone, some muscles are having very low tone. Instead of this, they will give you some muscles are having very high sorry, some muscles are having high reflexes, some muscles are having low reflexes. Okay, so you have to be thorough with the UMN and LMN lesions. Coming to complete occlusion of ASA. Complete occlusion of ASA में dorsal column are spared. बाकी सब जाएंगे. बाकी सब में we only know one thing, spinothalamic tract. तो pain and temperature गायब. Coming to tabes dorsalis, उल्टा. इसमें pain and temperature रहेगा, but proprioception, vibration, pressure गायब. Syringomyelia, pain, temperature गायब, and between syrinx will be expanded. Cauda equina syndrome, lower body के सारे sensory गए, bladder गया. Okay, so this is what one line you have to pick out and you are good to go. Okay, sometimes it become confusing, so तभी आपको detail में पढ़ना पड़ेगा. UMN and LMN lesion के देख के पढ़ना पड़ेगा. All right, so let's move ahead. Poliomyelitis, छोड़ दो. They never ask. Brown-Sequard syndrome. Brown-Sequard syndrome, very high yield, and every time you are going to make mistake because इसमें समझने वाला कुछ नहीं. You don't have to remember anything. You just have to, sorry, you don't have to understand anything. You have to remember only. Okay. So ये diagram आप याद कर सकते हो, but along with the diagram, you have to remember what is happening here. Okay. So let's just see what is happening. First point, hemisection of spinal cord. Hemisection is very important. There is not complete section, there is hemisection. Okay, this word, ये वाला question NEET PG भी बहुत बार पूछ चुका है, and USM is also asked so many times. Hemisection word is very important. Okay, now let's see what happens. Ipsilateral loss of all sensation at the level of lesion. Okay, ipsilateral element sign at the level of lesion. Okay, ipsilateral UMN sign below the level of lesion. Ipsilateral loss of proprioception, vibration and light below the level of lesion. मतलब dorsal column का problem आया. Okay, contralateral loss of pain temperature below the level of lesion. Contralateral, so यहाँ पे spinothalamic आया. Okay, so this is what you need to remember. राइट साइड में लीजन हुई है तो लेफ्ट साइड का पेन टेम्परेचर जाएगा. राइट साइड में लीजन हुई है तो राइट साइड का वाइब्रेशन प्रोप्रियोसेप्शन जाएगा. राइट साइड में लीजन हुई है तो वो लेवल पे एलिमेंट वो लेवल पे सारे सेंसेशन जाएंगे एंड यू विल बी गेटिंग एलिमेंट साइंस और उसके नीचे यूएमएन साइन. दिस इज हाउ यू टू रिमेंबर एंड सी इफ यू आर थोरो विद द सिम्टम्स ना कि कॉन्ट्रालेटरल में पेन टेम्परेचर गया, इप्सिलैटरल में वाइब्रेशन प्रेशर प्रोप्रियोसेप्शन गया, इप्सिलैटरल में लीजन के नीचे यूएमएन साइन गया, लीजन पे सेंसरी गया, लीजन पे एलिमेंट गया. Okay, this is how you can remember 5 important points of Brown-Sequard syndrome, and along with that, hemisection of spinal cord, very important. Okay, now instead of the symptoms, they will give you tract के नाम दे देंगे. Okay, there is a contralateral loss of pain temperature. Contralateral loss of pain temperature है, it means there is a problem in the spinothalamic tract. Okay, so you should be thorough with the tracts and the function. That is what step 1 is asking you. ओके, एंड Brown-Sequard को आप याद कर लेना इप्सिलैटरल और कॉन्ट्रालैटरल में क्या हो रहा है. डेफिनेटली दिस इज गोइंग टू कम 100% एक क्वेश्चन आएगा. ऑलराइट, मूविंग ऑन टू फ्राइडरिच एटेक्सिया. इट इज अ टाइप ऑफ ट्राइन्यूक्लियोटाइड रिपीट सीक्वेंस वाला. देख लेते हैं. ऑटोसोमल रिसेसिव है, ट्राइन्यूक्लियोटाइड डिसऑर्डर GAA. क्रोमोसोम 9 इज इंपॉर्टेंट. क्रोमोसोम 9 इज इंपॉर्टेंट. इट एनकोड्स frataxin. Frataxin is an iron binding protein. Okay, now degeneration of lateral corticospinal tract, spinocerebellar tract, dorsal column. Okay, ये सेम है जो B12 में हमने देखा है. Okay, B12 deficiency में भी सेम ट्रैक्स है. So now what are the presentation? Staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, hematose, diabetes mellitus, hypertrophic cardiomyopathy is the cause of death and present in kyphocoliosis. Now remember I told Charcot-Marie tooth में भी pes cavus and hemato दिख रहा है, and here also hemato दिख रहा है. But one thing, they will never ask you at step 1 level. Okay, at step 1 level they are never going to ask you about the hemato in Friedreich ataxia. Okay, अगर पूछ लिया ना तो आपका लक खराब है. All right, so they are never going to ask you about the hemato in Friedreich ataxia, but definitely they are going to ask you about hemato in Charcot-Marie tooth disease. And if फ्राइडेज अटैक्सिया में पूछ लिया तो देखना डीमाइलिनेशन किस में है और डीमाइलिनेशन किस में नहीं है, ट्राई न्यूक्लियोटाइड रिपीट सीक्वेंस किस में है, जेनेटिक डिजीज किस में है. ओके, कीप योर ब्रेन ओपन एंड देन सॉल्व इट. ऑलराइट, सो दे आस्क वन इंपॉर्टेंट क्वेश्चन इज स्किफोलियोसिस दिखती है एंड द कॉज ऑफ डेथ, द कॉज ऑफ डेथ हियर इज हाइपरट्रॉफिक कार्डियोमायोपैथी. Okay, hypertrophic cardiomyopathy is important, so you need to keep this in mind and then only do. Okay, just give me a minute. Alright, so Friedreich ataxia also done. इसमें याद रखना कि sometimes they ask you about the gene जो encode gene को encoding कर रहा है ना, they instead of that gene they will ask you iron binding protein. Okay, they are very nicely. Okay, so नाम की जगह they will be asking you the function of that gene. Alright, so we are done with the spinal cord syndrome and we are done with one genetic disease that is Friedreich ataxia. Brown Sequard syndrome में please ये याद रखना hemisection गलती करोगे तुम. Okay, so that's all about spinal cord and now let's come to common cranial nerve lesion. जैसे तो करने की जरूरत नहीं है. We have seen the functions of cranial nerve, so based on that you can easily do it. Facial nerve lesions में Bell's palsy, ये आपका इसमें इतना clearly दिया नहीं है, but they will definitely give you this image like this and they will ask you which nerve is associated with this. So like that you can do it. Okay, upper motor neuron lesion and lower motor neuron lesion they never ask, but Bell's palsy के रिलेटेड एक दो सवाल आए हैं, so let's just do it. लीजन लोकेशन, अपर मोटर न्यूरॉन लीजन आया तो ओके, फेशियल न्यूक्लियस ये सब छोड़ दो. अफेक्टेड साइड कॉन्ट्रालैटरल एंड इप्सिलैटरल. ओके, इन द क्वेश्चन दे विल आस्क यू कि बेल्स पाल्सी हुआ है, सो अपर मोटर न्यूरॉन की वजह से हुआ है, लोअर मोटर न्यूरॉन की वजह से हुआ है, एंड दे विल पॉइंट एट कि ये वाला पार्ट अपर की है या लोअर की. दे विल आस्क यू दिस इज बिकॉज ऑफ अपर मोटर न्यूरॉन और लोअर मोटर न्यूरॉन. ओके, सो यू हैव टू कीप दिस इन माइंड. Muscles involved, lower muscles of facial expression, upper and lower both. Forehead involved, spread. Forehead affected. तो forehead affected हुआ तो it means lower motor neuron. Okay, ऊपर वाला है lower motor. Is that clear? That's how you will be distinguishing. Mostly they won't be asking this. They will just be focusing with Bell's palsy किसके साथ दिखती है, क्यों दिखती है, कौन सी nerve के साथ दिखती है. All right. So with this we are done with the pathology part of CNS. Okay. Now one important thing I want to tell you is here अगर आपकी न्यूरो बाकी है, ओके, इफ यू आर ऑन लो टाइम, अगर टाइम कम है ईयर छोड़ दो. ओके, बिकॉज इन ईयर दे आर नॉट आस्किंग एनीथिंग. एनबीएमई उठा लो, एक क्वेश्चन मुश्किल से मिलेगा. ओके, एंड इन एग्जाम आल्सो दे डोंट आस्क. वन थिंग दे लाइक टू फोकस इज दिस वन. सी ये जो ईयर की ओटाइटिस एक्सटर्नल ओटाइटिस मीडिया है ना, दिस यू कैन डू फ्रॉम द माइक्रोबायो पार्ट. फॉर दैट यू डोंट नीड टू डू इन डिटेल ओवर हियर. Okay, so leave this and do this. They ask about this vertigo. They love to ask about vertigo, and in vertigo maybe they ask only one thing, that is BPPV. कहाँ गया BPPV? Yeah, this is what they ask, BPPV. बाकी कुछ भी नहीं पूछते वो लोग. And BPPV भी पूछना है ना तो very rare cases में. Ear is not a focus in step 1. Ear step 2 सीखे में आएगा. So इसमें मेरे को कुछ भी high yield नहीं लग रहा है. But BNB अगर आप कर रहे हो so make sure you know what is mania disease and what is BPPV. I think all of you are graduate and in the final year. So ENT तो आपने कर ही ली होगी. So just keep the background in mind. ENT they never ask in the step 1. Let's go to optal. Optal they will ask. एनआर करने की जरूरत नहीं है, लोकेशन करने की जरूरत नहीं है. ओके, जस्ट फोकस ऑन द फंडोस्कोपिक इमेजेस. ओके, फंडोस्कोपिक इमेजेस आर वेरी इंपॉर्टेंट. ओके, रिफ्रैक्टिव एरर्स करने की जरूरत नहीं है. कंजक्टिवाइटिस सिंपल है, पिंक आई के साथ आएगा, सो कोई भी बता देगा ये तो. ओके, कंजक्टिवाइटिस इज नॉट दैट इंपॉर्टेंट. सो ऑप्थेल में आई एम सेइंग अगेन, डोंट वेस्ट टाइम ऑन कि समटाइम्स यू नो व्हाट हैपन, व्हाट पीपल डू इज ऑप्टल का पार्ट देख के दे आर लाइक ओ आई हैव टू स्टडी ईएनटी एंड ऑप्टल इन डिटेल नाउ. नो, यू डोंट हैव टू. जस्ट सी फर्स्ट एड में क्या दिया हुआ है. जस्ट लुक एट द आई इमेजेस एंड फंडोस्कोपिक इमेजेस, यू आर गुड टू गो. ऑलराइट, so let's just see इसमें क्या करना है. Cataract. Cataract is important. They have asked many questions, and one like most common case they will give you about cataract in sunlight में farms or tractor. If the question specifically will say that the patient was a farmer and he used to plow his field with the help of a tractor in sunlight. Okay, so sunlight is one of the risk factor causing cataract. तो देखते हैं और क्या क्या दिया हुआ है. Painless often bilateral opacification of lens can result in glare and decreased vision, especially at night. Okay. So acquired risk factors may age, tobacco, alcohol, excessive sunlight, prolonged glucocorticoid use, etc., etc. Congenital may you have galactosemia, galactokinase deficiency, trisomy 13, 18, 21, torch infection, everything. Okay. Surgical नहीं पूछेंगे, treatment नहीं पूछेंगे. They will just ask you cataract के risk factors क्या है. You need to be able to diagnose कि हाँ, the question is talking about cataract. Okay, that's it. Aqueous humor pathway छोड़ दो, कुछ नहीं आएगा. ओके, ग्लोकोमा छोड़ दो, कुछ नहीं आएगा. जस्ट रिमेंबर वन थिंग इन ग्लोकोमा, रिस्क फैक्टर्स. रिस्क फैक्टर्स कहाँ दिए हुए इसमें देख लेते हैं. या एज, फैमिली हिस्ट्री, डायबिटीज मेलाइटस. और क्लोज में रिस्क फैक्टर्स ऑलमोस्ट सब में सेम ही होगा. ओके, ग्लोकोमा they don't ask the diagnosis of glaucoma. What they ask in glaucoma is they will be asking you anti-glaucomic drugs. ओके, एंटी ग्लाइकोमिक ड्रग के बारे में बहुत पूछेंगे, बट ग्लाइकोमा एज अ डायग्नोसिस दे वोंट आस्क. ओके, ग्लाइकोमा का स्टेप 2 सीके में बहुत है. ऑलराइट, सो लीव दिस, जो काम का नहीं है लीव दिस. एंड if they want to ask about glaucoma, you will में one question is there. They will say there is increase in cupping. Normal there is increase in cupping. बस one word, one line दे देंगे, increase in cupping and rest all blah blah blah. So that is what your diagnosis is, glaucoma. बाकी कुछ भी करने की जरूरत नहीं है. Don't waste your time. Alright, let's see. Retinal disorder. Now yes, this is very important. ये सारे very important. So we will do this in detail. Okay. Till before this, सिर्फ cataract important था, nothing else. So you can literally avoid them. UL में 2-3 questions are there. So वो देख लो कि कैसे questions आ सकते हैं. बाकी डिटेल में करने की कोई जरूरत नहीं. Alright. Coming to retinal disorder, the first one, age-related macular degeneration. Age-related macular degeneration. Let's just see उसमें क्या है. Dry and wet. Dry is most common. The gradual decrease in vision with subretinal deposits and decrease in vision due to bleeding due to choroidal neovascularization. See, now one thing they have not given here, and you will ask is how the eye will be presented to you. It will be grayish. It will be green. Subretinal discoloration. Okay, this is important. Now one thing they have asked is ये जो dry है ना, तो यहाँ पे deposit होते कहाँ है? Where are the deposits they have? This is not given over here, so you should know. This is given in the old edition of first aid. So इसमें पता नहीं why they removed it. Let's just write it down कि ये जो deposits होते हैं वो कहाँ होते हैं? Between Bruch membrane and retinal pigment epithelium. Retinal pigment epithelium. इन दोनों के बीच में होते हैं deposit. So it is dry degeneration. Okay, that's it. Alright, wet के लिए तो यही है choroidal neovascularization. Okay, so आपको याद होना चाहिए. And one important feature is scotoma. Loss of central vision, scotoma. Okay, so this 2-3 lines, central scotoma आया, age greater than 50-60 years आया, and they ask about the deposits, then you should think about age related macular degeneration. All right, moving on to diabetic retinopathy. Diabetic retinopathy में there are non-proliferative and proliferative. Non-proliferative is most common. So इसमें microaneurysm, hemorrhage सब आएगा, retinal neovascularization सब आएगा. Okay. Now you have to remember the images. Okay, images बहुत important है. Now see, this is what they are talking about, the age-related degeneration, and this is what about the diabetes, hemorrhages. Now one thing, the problem पता है, I'll tell you. Now see, now one problem. Okay, one problem while solving the opthal questions is कि as we haven't studied the opthal in detail, so it becomes very difficult for us to identify the fundoscopic images. Fundoscopic image में क्या दिया हुआ अपने को समझ ही नहीं आएगा. Okay, so what they will do is, like how I have seen the questions is, they mostly ask about this, they mostly ask about this, and they ask about this रेटिनल डिटैचमेंट. बाकी मैंने क्वेश्चन देखे ही नहीं है. बाकी सब में कैसे पूछते हैं, उसमें फंडोस्कोपिक इमेज नहीं देते. दे डोंट गिव फंडोस्कोपिक इमेजेस इन दैट. दे गिव द रिटन पैथोलॉजी, द रिटन फंडोस्कोपिक इमेज कि ये फंडोस्कोपिक इमेज में ऐसा दिखा. ओके, but still you have to be thorough with all the images. It is difficult, I know, but you have to do. So let's just see all the conditions one by one. So इसमें तो देख ही लिया, hemorrhages, cotton wool spots, hard exudates, everything will be seen. Okay, history में there will be diabetes. Okay, that's it. Coming to hypertensive retinopathy, spasm, sclerosis, सब कुछ दिखेगा, सब कुछ दिखेगा. यहाँ पे भी cotton wool spots है, यहाँ पे भी cotton wool spots है. It will be common everywhere. But diabetic में diabetes रहेगा, और hypertension में they will say this, hard exudates may be seen. Okay, hard exudates may be seen, and in the history hypertension will be given. So hard exudates कैसे दिखते हैं, ये रहे hard exudates, ये रहे hard exudates, ये रहे cotton wool spots. ओके, तो ऐसे ऐसे एक एक लाइन करते जानी है आपको, एंड यू आर गुड टू गो. रेटिनल आर्टरी ऑक्लूशन, ब्लॉकेज ऑफ सेंट्रल और ब्रांच रेटिनल आर्टरी यूजुअली ड्यू टू एम्बोलिज्म. ओके, लेस कॉमनली ड्यू टू जायंट सेल आर्टराइटिस. एंड यहाँ पे रेटिना विथ चेरी रेड स्पॉट, दिस इज वेरी इंपॉर्टेंट. चेरी रेड स्पॉट बहुत बहुत इंपॉर्टेंट है, because they have asked so many questions regarding cherry red spot, and I'm sorry, this is what cherry red spot is. This is what cherry red spot is. Uh-oh. ये है चेरी रेड स्पॉट. मोस्ट कॉमनली आज यही पूछते हैं, रेटिनल आर्टरी ऑक्लूशन मोस्ट कॉमनली आज, एंड चेरी रेड स्पॉट इज वेरी इंपॉर्टेंट. ओके, बाकी कुछ नहीं. रेटिनल वेन ऑक्लूशन, ब्लड एंड थंडर अपीयरेंस, बस इतना ही याद रखो. ब्लड एंड थंडर अपीयरेंस, रेटिनल वेन ऑक्लूशन. देखते हैं, ये रहा, आई टोल्ड यू ना, ये वाला ब्लड एंड थंडर अपीयरेंस. ओके, कमिंग टू रेटिनल डिटैचमेंट. तो रेटिनल डिटैचमेंट में भी भूल जाओ, कुछ भी भूल जाओ, जस्ट इतना याद रखो, फंडोस्कोपी में ओपेसिफिकेशन एंड व्रिंकलिंग ऑफ डिटैच रेटिना seen in vessel direction. ये रहा, see, you can say this, you can say this, retina is being detached. So this is what retinal detachment is. Okay, so three, before going pigmentosa, let's just discuss again. डायबिटिक रेटिनोपैथी होगी, हाइपरटेंसिव रेटिनोपैथी होगी, दोनों में फीचर्स कॉमन है. ओके, बट हाइपरटेंशन में दे विल गिव हाइपरटेंशन, डायबिटिक में डायबिटिक देंगे. एज रिलेटेड मैकुलर डीजनरेशन, फंडोस्कोपिक इमेजेस में देयर विल बी येलो येलो स्पॉट्स. ओके, एंड दे विल आस्क यू कि कौन से दो मेम्ब्रेन के बीच में डिपोजिशन होती है. ओके, सो यू शुड बी नोइंग दैट. अनदर थिंग, सेंट्रल स्कॉटोमा, सेंट्रल विजन जाएगा, दैट इज मोस्ट कॉमनली इन स्टेप 1 दे आस्क अबाउट एज रिलेटेड मैकुलर डीजनरेशन. Coming to retinal artery occlusion, in the question they will specifically mention cherry red spot. अगर mention नहीं किया तो fundoscopic images में cherry red spot कर लेना. Coming to retinal vein occlusion, they will give blood and thunder occlusion. Retinal detachment, retinal layer will be detached. You will be seeing that the retinal layer is detached. Another term that they use for this is you will see floaters. Okay, इसमें भी दिया होगा floaters. Yeah, see, डिटैचमेंट दैट इज फ्लोटर्स एंड लाइट फ्लैशेस. ओके, सो रेटिनल डिटैचमेंट की जगह फ्लोटर्स अगर मेंशन करते हैं, थिंक अबाउट रेटिनल डिटैचमेंट. कमिंग टू रेटिनाइटिस पिगमेंटोसा. Retinitis pigmentosa is important because here one important line is there. Just a minute. Group of inherited dystrophies. Early symptoms, night blindness, nyctalpia is important, and peripheral vision loss is important. So triad of optic disc pallor, retinal vein vessel attenuation, and retinal pigmentation with bone spicule shaped deposit. This is important. Bone spicule shaped deposit. ये है आपका रेटिनाइटिस पिगमेंटोसा. अगर आप इसको जूम करके देखो, बोन स्पाइक्यूल शेप डिपॉजिट. Okay, so this is what we are talking about in retinitis pigmentosa. Coming to papilledema. Papilledema, optic disc swelling usually bilateral due to increase in ICP, results from impaired, ये सब ठीक है. Elevated optic disc with blood margin. देख लो ये blood margin, cupping blood margins है. Okay, so this is what about optic disc, sorry, papilledema. All right, now moving to leukocoria. Leukocoria is loss of red reflex. Important causes in children include retinoblastoma. Okay, अगर retinoblastoma है, so you have leukocoria. All right, and another thing is in papilledema, I forgot to tell you one thing. Papilledema is associated with the sixth nerve palsy. Okay, तो ये याद रखना, sixth nerve palsy is very important. And here leukocoria में loss of red reflex, important causes in children, retinoblastoma के साथ ये आएगा. All right, so I think that's it. एंड या कंजेनिटल कैटरेक्ट, और इसके साथ वन मोर पॉइंट, टॉक्सोकेरियासिस. टॉक्सोप्लाज्मा के जो होता है ना, दैट इज आल्सो बिकॉज ऑफ ल्यूकोकोरिया. ऑलराइट, नेक्स्ट वन इज यूवीआइटिस. नॉट इंपॉर्टेंट, यू कैन अवॉइड दिस. जस्ट रिमेंबर HLA-B27 दैट वी स्टडीड विद एंकाइलोसिंग स्पॉन्डिलाइटिस. ओके, एंकाइलोसिंग स्पॉन्डिलाइटिस में तीन होते हैं, कान सी, कान पी, कान बैंडनी. ओके, so uveitis is associated with that. Separately they won't ask anything. Moving on to the pupillary control. Now here कोई क्वेश्चन नहीं आएगा इसमें से. No question will be coming from here, but what will be coming is you have to understand this. You have to understand and you have to remember the pathway कि first neuron कहाँ पे और second neuron कहाँ पे and how this pathway is going on. You have to understand this because NBME में तो एक भी question नहीं है, but UL is having question. Okay, so just understand this. If your luck is bad, you will be given one question regarding this. Okay, बाकी कुछ करने की जरूरत नहीं है. And yeah, one important point I forgot to tell you in the beginning of ophthalmology is UWorld में जितने questions है ना, I think there are 45 to 50 questions in ophthalmo. Okay, I आप select करोगे ना, 45 to 50 questions है. Ratify that. उसके बाद step 1 में nothing will be there. Similar is the case of anatomy. Okay, if you go subject wise, UWorld में anatomy में I think 100 questions के करीब है. Ratify that. Outside that, no extra questions will be there in anatomy. Okay, so optha and anat आप रट डालो what is given in UL. Each and every question you should be thorough with. Okay, because what happened with me, anatomy के UL में there were 2 questions and exactly the same questions came to me in the real exam. Okay, because real exam में मेरे को याद था कि मैंने कहीं तो ये question देखा हुआ है. Okay, and I was not remembering it. So that is my experience. From my experience, I'm telling you, anatomy का और optha का आप questions रट डालो along with the first day that I'm telling you. Okay, you will be good to go in these 2 subjects. Coming to relative afferent pupillary defect, Marcus Gunn pupil, they don't ask in detail. Ignore it. Okay, but इतना एक point पूछ सकते हैं. When light is swung from normal eye to the affected eye, both pupils dilate instead of constricting. अगर ये line आई, Marcus Gunn pupil. Okay, Horner syndrome. This is important. Horner syndrome is important. Sympathetic denervation of face. So you should know the 3 symptoms: ptosis, meiosis, and aniatropy. ये तो main है Horner syndrome के symptom. Now here they ask you what is the first neuron, where is the second neuron located, and where is the third neuron. They really ask you this. Okay, and you should be thorough with this. First neuron आएगा pontine के पास, pons में. Second neuron आएगा stellate ganglion में. Third neuron आएगा near the carotid artery. Okay, you should be thorough with this. Remember this diagram. UL करोगे समझ जाओगे. UL में एक question है regarding this. All right. Moving to ocular motility, and here you have to remember this formula: LR6 SO4 3. LR6 मतलब lateral rectus 6, superior oblique 4, and rest all muscle third cranial nerve. ये आपने कर लिया, good to go. All right. So that's it. We are done with this. And yeah, ये image याद रखना. Again, UWorld करोगे, ऑप्थाल में जितने भी MRI images है, ratify it. Okay, basically whole ophtha from UWorld you have to ratify. All right, moving to cranial nerve damage. See, now in the cranial nerve damage, now they will give you so many things. You have to pick out one symptom, one liner. Now what is that one liner? If they want to ask you about the cranial nerve 3 damage, na, they will give you I like this, that is blown out and down. Okay, if they want to give the cranial nerve 4, na, they will give you the eye is going up, and they will say you ki, while climbing downstairs, patient has to keep his face down. Like he has to do his face down because आँख तो ऊपर ही है, नीचे नहीं जा रही. Okay, so cranial nerve के साथ साथ you should be thorough कि कौन से muscles में damage हो रही है. And how you will remember this? Just remember this LR6 SO4 3. Okay, so lateral rectus की 6 cranial nerve palsy. अगर ये cranial nerve 4 है तो superior oblique में palsy है. superior oblique में palsy है तो eye नीचे नहीं होगी. Okay, you should be knowing the actions of the muscles also. Okay, actions of the muscles यहाँ पे देख लेना. Okay, बाकी कुछ भी नहीं है. It's simple. Optha is very simple. Be thorough with the UL and what all I am telling you. ओके, सुपीरियर ऑब्लिक नीचे नहीं कर पाएगा, इंफीरियर ऑब्लिक ऊपर नहीं कर पाएगा. तो ये आपको पता होना चाहिए. सुपीरियर है तो ऐसा नहीं कि सुपीरियर में प्रॉब्लम होगी. ऑलराइट, एंड क्रेनियल नर्व 6 एबडक्ट नहीं कर पाएगी. ओके, लैटरल रेक्टस है तो ये साइड लैटरल की साइड आई नहीं जा पाएगी, आई मीडियल में रह जाएगी. दिस इज व्हाट इज हैपनिंग ओवर हियर. यहाँ पे भी मिडल में है, लेटर की तरफ नहीं जा रही है. ओके, so this is what you need to remember for cranial nerve palsy. बस इतना याद रखो. In the question they will definitely give you blown and down pupil cranial nerve 3, up pupil cranial nerve 4, and it's not going to abduct cranial nerve 6. बस इतना याद रखो, you will good to go for the question. Okay, moving ahead, we have visual field defects and this is very high yield. 99% ये सवाल आएंगे आपको. Just remember this pathway also. Just remember this presentation also. And remember कि कहाँ पे क्या problem हो रही है. Whether it is in the optic chiasma, whether it is in the optic nerve, whether it is in the right temporal lobe, right parietal lobe, central scotoma, sorry, ये occipital lobe, कहाँ पे आ रहा है. Remember each and everything. Remember this diagram also. They will give you A, B, C, D, everything. So this is very, very important. You must have seen many questions regarding this. Okay. Cavernous sinus, just remember the nerve. Nothing else. Just remember the nerve. They are मतलब NBME में भी नहीं है. UWorld में एक question है. So just remember the nerve and UWorld का देख लो presentation कैसा है. We are good to go. Yeah, I am making you write down few important points regarding that pupillary reflex, visual field defects में. Write it down for your summary. All homonymous hemianopia seen in optic tract lesion. Okay, optic tract की lesion होगा तो all everything will be homonymous hemianopia. Okay, homonymous hemianopia. It is because of optic tract lesion. Okay, this is first point. Second, okay, इससे एक example दे देता हूँ. So if it is right homonymic hemianopia and left homonymic hemianopia, right हुआ तो left optic tract, right left हुआ तो right optic tract. Okay, moving ahead. Due to dual blood supply of occipital lobe, macula is spared in lesion of posterior cerebral artery. Okay, तो ये दो पॉइंट याद कर लो because the question will be revolving around them. Rest is bitemporal hemianopia, quadrantopia, pie in the sky, pie on the floor. That is what everything you need to remember. And ये दो के around question ज़्यादा घूमेंगे, so make sure you know them. Okay. Moving ahead, internuclear ophthalmoplegia. Now here, if you are able to diagnose internuclear ophthalmoplegia, na, so just remember cranial nerve 6 and cranial nerve 3. And remember one thing, where is the lesion? Lesion is in MLF. Okay, lesion is in MLF. They won't go into detail over here. But अगर आपको detail में जाना है, so I am writing down few points for you for the safety. You can note it down. MLF. MLF जिससे INO होगा, internuclear ophthalmoplegia. So what is, how it will come to you? Affected side can't move medially. Okay. Second, sixth palsy. तो sixth palsy में affected side can't move laterally. Third, PPRF lesion. ये रहा पैरामीडियन पोंटाइन रेटिकुलर फॉर्मेट. ओके, तो PPRF लीजन हुआ तो can't go to side of lesion, मतलब जिस साइड लीजन है people can't go to that side, eyeball can't go to that side. Fourth, 1.5 syndrome. See, they have never asked 1.5 syndrome, but just write it down for your knowledge. INO plus gauge palsy on side of lesion. Okay. And yeah, differential diagnosis करना हो, this they have asked. Okay, so write it down. So first you will look at the eye. Okay, look at the eye. Second, trying to move medial or lateral. Medial or lateral. Third, if medial, then it is INO. If lateral, it is sixth nerve palsy. And this is what I have written over here. Okay, so ये आ सकता है differential diagnosis between INO and sixth nerve palsy. INO में क्या होता है, sixth के साथ तीसरी nerve की भी palsy होती है, sixth and third. Because what happens is, as you move the sixth nerve over here, the third nerve has to be activated and it should move over there, right? Lateral rectus के साथ medial rectus. When you look at the left, there is some coordination in the vein, in the MLF, that is causing the two nerves to act together. So when you look at the left, lateral rectus left में लेके जा रहा है left eye को, middle rectus left में लेके जा रहा है right eye को. Okay, so this is what the coordination is occurring over here. That is what INO is. They won't ask complicated questions as they are asked in ophthalmology. Simple आएगा, यही बताएंगे कि when the patient is looking at the left eye is moving properly, but the right eye is not able to move properly. Okay, so medial में नहीं हो पा रहा है. Okay, you get my point? Left देख रहे तो right eye medial नहीं हो पा रहा है, medial नहीं हो पा रहा है, मतलब there is a problem in INO. Did you get my point? Okay, I hope you got my point. All right. Then coming to the pharmacology, so guys, I am tired. Pharmacology कल कर लेंगे CVS के साथ. Let's just end it here today. Okay, pharmacology बहुत बड़ा है. I think 15-20 minutes तो जाएगा इसमें. Okay, so we are done with the CNS almost. We are done with the ophthalmo. We are done with the patho. Pharma छोड़ के सब कुछ कर लिया है. Okay, आज जो भी हमने पढ़ा, that was all about theoretical. There was nothing, some concepts apply करने जैसा कुछ नहीं था. You just have to pick out one line, symptoms, clinical presentation, and then you will be good to go. Yesterday what we did, that was all about applying the concept. कौन सा पार्ट है, या पार्ट है तो कौन सा क्या होगा. Okay, and believe my word, believe my statement, CNS is one of the easiest system if you know the information properly. And CNS के every block में 3 to 4 questions आएंगे, just like ethics. Ethics के 4 questions मान के चलो, CNS के 3 to 4 questions you can expect. So it is a very high yield. Give more time. Try to remember the information. Solve more questions again and again. Okay. Believe me, ऐसा कर लिया ना, CNS के साथ आपको प्यार हो जाएगा and you will love solving CNS questions. All right. So that's it. If you have any doubt, let me know. And if you want to have a meet with me, let me know. ये recording बंद करके I will call you personally. मलैया जी, आपको मीट करनी है तो क्लास के बाद मैं बंद करके मैं कॉल करता हूँ. सृष्टि एंड शेरिन, एनी डाउट?
No.
नो डाउट, सब क्लियर हो गया?
हाँ.
ओके, सो आई होप एवरीथिंग इज क्लियर. कल फार्मा के साथ CVS कर लेंगे, डोंट वरी. ओके, सो दैट्स इट, क्लास इज ओवर, यू कैन लीव एंड दैट्स इट.
Okay, thank you.
Okay, no worries, see you tomorrow.